I think this is probably just a little. All right. Hola, hola, how are you doing? All right. Carousel, hola, how are you? Angela, welcome, welcome. Rima, Cindy, I'm favored. Kevin, Kitty Maria, Sophia, welcome. All right, nice. Yeah, sorry about the time. I know I said 7. All right. But I had totally forgotten that I never really had much to eat. And so let me just kind of grab a bite before. So, and plus I try to figure out my hairstyle as well. Because I started doing this hair and then, yeah, it never does look good tonight. So I wanted it to be a little bit presentable. So I said, let me go ahead and try to do something. So that kept me up a little bit as well. All right. So thank you so much for tuning in. Okay, nice, nice. Oh, let me see. Manuel. Okay. KK, welcome. Or Marcia, Vernon. Oh, everybody jump off. Everybody jump off of the live. Okay. Hey, Marvin, how are you doing? Something on my teeth. I was eating rice and chicken nuggets, vegetarian chicken nuggets. Yeah. Are you hearing me loud and clear? Or I need to put in my little microphone. I think I'm loud. I'm loud enough, right? I think so. All right. So I guess we'll see other persons popping on later on. So we're gonna do GI, the GI system tonight. All right. So we'll have a few questions, and then from there, Sparks, how are you doing? Asantiwa, welcome, welcome. Thank you for liking up the live. Oh yeah, let's tap up the live. Let's try to get to 1,000. I'm not that needy. Let's try to get to 1,000. Thank you for the heart me, Sparks. We're not that needy. All right, so let's try to get to the 1,000. Well, let me see. Okay, 1,000 on the live, and then Watchman up and running. Welcome, welcome, welcome. And then we'll try to see. All right, so we'll be going through, we'll try to go for 100 questions related to the GI system. You can still always pop in, you know, whatever question. If you need an explanation on something, I'll try as best, you know, to answer. If it's not related to the questions here we're discussing. All right, so definitely do that. And then from there, as usual, the patients are with you, so you have to do something. You have to do something for the patient. You can't leave the patient without not doing anything. Oh, yeah, at work. Yeah, you can't leave the patient and not do anything. So please choose an answer. A, B, C, or D, and we'll see if you save the patient's life. All right? And that's all. Let me just check something here. Remember to go ahead and follow here. You can also subscribe to my YouTube page at ThinkNursing, where I share the long form content. So if you missed the live and you're joining in, you can always go over there and find the content posted on the page. All right. Thank you, thank you, thank you. All right. So we'll start out with some easy questions, and then from there, we will look at some harder questions. Oh, when I reach 1,000 yet? Can we try to go up to 1,000, please? All right, and remember to go ahead and share and send in your daily heart me, because I tend to forget all about those things. So definitely go up and share, you know, share, follow, and what else? You have to comment as well. Put down a little comment and tap, 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 tap. Yes, Sparks. Tap, 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 tap as well. And do your daily heart me. All right. So that's important. Not only for me, but for you as well. All right. Yeah, I'm gonna have to add some more moderators to my page, even though, you know, yeah. So Sparks, you know, I'm definitely gonna add you and everybody else on the other page. So just in case you guys passing through, then, you know, if there's anything else, you can just say your 1 and 2 words. All right. Some of them will teach us. So I think it's a peas. All right. So let's go. I already did add you. Totally forgot. Or Fire, can you add? Come to Jesus and be saved. Redeem, thank you so much. All right. Thank you for those encouraging words. All right, no problem. All right then. I think Fire can Fire. Are you able to add, right? You're able to add moderators, right? I think so. Yeah. All right. Let's get the live up to 5,000 and from there, but we'll do our questions either way. So I'm going to start out with some questions, about 15 questions that are very simple, straightforward, and just press down on their name. Just press down on the name, and then I think it should give you the option to add moderator. I don't know. So probably I added the Sparks before if you weren't the one. But we can do that at another time. All right. So first question of the night, and thank you so much for joining in. First question of the night is, which organ is responsible for producing bile? As we say, A, B, C, or D. Not a problem. A, B, C, or D. A, stomach. B, liver. C, pancreas. D, gallbladder. So which organ is responsible for producing bile? A, the stomach. B, liver. C, pancreas. Or D, gallbladder. Liver. Fire Kush says liver. A, Sante says stomach. Okay. Do we have anybody else? We have 16 persons. Just one more person wanting to save. Spark says A. Melissa says C, the pancreas. So whoever it says B is correct. The liver is the one that produces bile. All right. And then the gallbladder stores it. What does the pancreas produce? What does the pancreas produce? Insulin. Okay. Nice, nice. And what does stomach produce? What does stomach produce? Sulfuric, hydrochloric acid. All right. I'm gonna just say hydrochloric acid. All right. The other one, a client asks, stomach acid, definitely. I heard A as liver. Oh no, sorry. So A was the stomach, B was the liver, C was pancreas, and D gallbladder. Sorry. All right. But never mind. Yeah, B is the answer. All right, the liver. Where does so a client asks what the gallbladder does. What is going to be the best response? A, it makes digestive enzymes. B, it stores bile. C, it produces insulin. Or D, it absorbs nutrients. So if someone asks you what the gallbladder does, the best response is going to be A, it makes digestive enzymes. B, it stores bile. C, it produces insulin. D, it absorbs it. So yes, so B, it stores bile. Correct, everyone. All right, so the gallbladder stores and releases bile into the small intestine. Where does most nutrient absorption occurs? A, the stomach. B, the small intestine. C, large intestine. D, esophagus. So where does most nutrient absorption takes place? Is it A, the stomach, B, the small intestine, C, the large intestines, or D, the esophagus? So see A, B, okay. All right, so small intestines. Definitely the small intestines absorbs most of your nutrients. All right, what does the large intestines do? What does the large intestines do? What does that absorb? So it absorbs your water and your electrolytes. All right. Okay. Which food should the client with a GI, with gastroesophageal reflux disease or GERD avoid? So if you have someone with GERD, which food should they avoid? A, baked chicken. B, oatmeal. C, spicy chili. D, steamed broccoli. So which food should a patient with GERD avoid? A, baked chicken. B, oatmeal. C, spicy chili. D, steamed broccoli. Definitely. Anything that is acidic, you want to encourage them to avoid it, all right? Because it's going to worsen their symptoms. Which position helps relieve the patient with GERD? A, lying flat. B, a supine position with pillows. C, sitting upright after meals. D, Trendelenburg position. So you have a patient that has GERD. Which is the best position for that patient to relieve their symptoms? A, lying flat. B, supine with pillows. C, sitting upright after meals. And D, Trendelenburg position. So everyone says C, good. Sitting upright after meals, all right? Helps with the reflux there. What is a common symptom of appendicitis? A, left lower abdominal pain. B, right lower abdominal pain. C, burning epigastric pain. D, shoulder pain. So what is a common symptom of appendicitis? A, left lower abdominal pain. B, right lower abdominal pain. C, burning epigastric pain. D, shoulder pain. So I have B, A, C. So whoever says B got it correct. The right lower abdominal pain. All right. And remember your Matt Burney's point. All right. So right lower abdominal pain is location for your appendicitis. Okay. All right. So epigastric pain, burning epigastric pain would be related to what? So if a patient is having burning epigastric discomfort, you're thinking along the line of what? GERD, definitely. All right. And we did ask this question, what is the function of the large intestines? A, digest proteins. B, absorb water. C, produce bile. D, secrete insulin. B, okay, yes, B, absorb water. All right, and we said that what organ produces bile? Okay, and which one stores it? So the bile is produced by the liver, and which one stores it? Which organ stores the bile? The gallbladder. All right, nice. Which finding is most concerning in a client with cirrhosis? A, loss of appetite. B, jaundice. C, confusion. D, fatigue. So you have a patient that has cirrhosis. Which finding is concerning for you as a nurse? A, loss of appetite. B, jaundice. C, confusion. D, fatigue. Okay, so I see C. Nice. So confusion, what are you thinking along the line of confusion? What are you thinking in terms of diagnosis? Hepatic encephalopathy, definitely. All right, that is one of the serious complication of it. All right, the others usually, you know, it's gonna be there, it's gonna be present, but the one that you're more concerned about is the hepatic encephalopathy. A nurse reviews labs for a client with hepatitis. Which result would be expected? A, elevated liver enzymes. B, decreased bilirubin. C, increased hemoglobin. D, low potassium. So a nurse is reviewing the labs for a patient with hepatitis. Which labs would be expected? A, elevated liver enzymes. B, decreased bilirubin. C, increased hemoglobin. D, low potassium. A, D. So A, elevated liver enzyme. D, low potassium. All right, so I see elevated. Erin, peritonitis. I'm not so sure what you're talking about there. But whoever says A, the elevated liver enzyme, oh, sorry. So a nurse reviews labs for a client with hepatitis. Which result would be expected? A, elevated liver enzymes. B, decreased bilirubin. C, increased hemoglobin. D, low potassium. So a few persons says A, the elevated liver enzymes, which is correct. Yes. So we're doing the GI system. So we're trying to cover as much questions regarding the GI system. And we're looking at different areas of the NCLEX itself. All right. So we'll try to get some pharmacology questions, med surg, and a mixture of everything. All right. Related to GI. But in the meantime, we will go ahead and, kind of pull the brain a little bit, depending on what the answers are and the questions. All right, thank you so much, TS Music, for tuning in. Erin is asking, hypocalcemia can happen because of activation, but that's later. Okay, yes. Princess. All right, so thank you so much, guys, for tuning in. If you haven't followed us yet, go ahead and top up the live and, just follow. We do the NCLEX questions on Tuesdays and Thursdays and popping questions or, chit chat during the week at 7 as well. All right. The priority nursing action for a client with vomiting. Let's go back to that question. A nurse reviews labs for a client with hepatitis. Which result would be expected? And that is the elevated liver enzymes. All right. Liver inflammation causes changes in your ALT and your AST levels, causing them to rise. All right. The priority nursing action for a client vomiting large amounts of blood is A, check bowel sounds. B, maintain airway. C, give antiemetics. D, start a clear liquid diet. So the priority nursing action for a client that is vomiting blood is to A, check bowel sounds. B, maintain airway. C, give antiemetics, and D, start clear fluid. So B, maintain airway. Definitely. All right, so you want to go ahead and maintain your airway. Just because of because of the vomiting, the excessive blood, it can actually cause blockage and cause aspiration and all. So you want to maintain the airway for that patient. All right, check bowel sounds. Are you worried about the bowel sounds right about now for this patient? No, we're worried about the bowel sounds for everybody, but not at this time. All right, remember, look at the keywords priority in the questions, and always remember, start with your ABCs, airway, breathing, circulation, to try and decide who you'll see first, and then also use your assessment. All right, give antiemetics. Yes, we'll eventually give that. Start a clear liquid diet. No. All right, this patient is going to be NPO. You give the patient anything to drink, the patient is going to keep on vomiting it up. All right. That will be reading into the question. Yes, and remember, always go ahead and just answer the question as how it is presented. All right, you don't have any extra patients dealing with. If it is just the one patient in the scenario, use that one patient and answer your question. All right, don't add anything, don't take away anything from the question. You're not short staffed, you have everything under the sun to work with regarding the patient. All right, so don't read into the question when you're thinking about your NCLEX here. All right. Which vitamin deficiency is common after gastric bypass surgery? Okay. So which vitamin deficiency is common after gastric bypass surgery? RN, Vanessa. All right. But the questions will benefit, any one of the NCLEX you're doing. Whether you're doing the PN, RN, yeah, all right. Or the RENR, which is the regional exam for the Caribbean. So which vitamin deficiency is common after gastric bypass surgery? A, vitamin C, B, vitamin D, C, vitamin B12, or D, vitamin A. So you have a patient that has gastric bypass surgery. Which vitamin D are you expecting that they're going to be having a deficiency in? A, vitamin C, B, vitamin D, C, vitamin B12, and D, vitamin A. Erin says vitamin B12 because of the loss of the intrinsic factor. Definitely. All right. So the stomach plays that important role there. A nurse is caring for a client with diarrhea. The priority risk is A, low blood sugar, B, fluid and electrolyte imbalance, C, high blood pressure, D, joint stiffness. So you have a patient that is having diarrhea. What are your priority? Okay, so the priority risk here is going to be B, fluid and electrolyte imbalance. What are some of the fluid, the electrolytes you're thinking about for this patient that they're losing? So you have a patient that is having excess, okay, sodium. So your sodium, potassium, all of those things. All right, so definitely make sure you're monitoring. Yes. All right, so B is the answer, fluid and electrolyte imbalance. So prolonged diarrhea causes dehydration and electrolyte loss. Which client statement indicates understanding about preventing constipation? A, I will drink 6 to 8 glasses of water daily. B, I will avoid exercise to rest my bowels. C, I will eat more cheese and white bread. D, I will take laxatives every day. So which client statement indicates understanding about preventing constipation? A, I will drink 6 to 8 glasses of water daily. B, I will avoid exercise to rest my bowels. C, I will eat more cheese and white bread. And D, I will take laxatives daily. A. Nice, good. All right, so you know that you need fluids, fiber, activity, all of those increase with your preventing constipation. All right, so that wasn't bad, right? Let's try some other questions. All right, so let's go back to... And thank you guys for tuning in. Remember to go ahead and tap up the live, okay? Tap up the live, share it. And we're doing all GI questions tonight, as much as we can when it comes onto the GI system. All right. And remember, whatever you don't know, still go ahead and save your patient. Choose an answer. All right. Choose an answer. And no, it's not that easy. Those were 25 easy questions. So we're going to go to some difficult questions now. Audrey, glam girl. All right. So a client with cirrhosis develops ascites. Which nursing intervention is most appropriate to include in the plan of care? A, encourage a high sodium diet. B, measure abdominal girth daily. C, increase oral fluid intake. And D, position the client flat in bed. So a client with cirrhosis develops ascites. Which nursing intervention is most appropriate to include in the plan of care? All right, so we have B, which is measure the abdominal girth daily. So the other options: A, encourage high sodium diet. C, increase oral fluid intake. Or D, position the client flat in bed. So yes, B is the correct answer. Measuring the abdominal girth. What are you thinking about when it comes on with ascites? Why are you checking that, that abdominal girth? Are we just doing it because, what are you concerned about? Fluid, definitely the accumulation of fluid in the peritoneal cavity there. So monitoring abdominal girth provides an objective measurement of fluid changes. Sodium and potassium are usually restricted, and elevating the head of the bed helps with breathing, not laying flat. All right. So fluid is increasing or not? It is yes. So you're checking to see if it is building up. All right. A client with a nasogastric tube after bowel surgery suddenly develops abdominal distension, abdominal distension, nausea, and decreased drainage from the tube. What is the nurse's priority? So you have a client with nasogastric tube after bowel surgery suddenly develops abdominal distension, nausea, and decreased drainage from the tube. What is the nurse's priority? A, irrigate the tube with 100 mils of tap water. B, reposition the tube and check for kinks. C, notify the provider immediately. D, increase suction pressure. So which of the answer it is? So a client has a nasogastric tube after bowel surgery, starts having abdominal distension, nausea, and decreased drainage. Okay, so I see a few persons says C. They're going to notify the provider immediately. I think I saw another. And someone says D, increase suction pressure. So the client has a nasogastric tube after bowel surgery, suddenly develops abdominal distension, nausea, and decreased drainage from the tube. What is the nurse's priority here? So Princess says B. Why you say B, Princess? So she says B, which is reposition the tube and check for kinks. So always remember, you are to assess your patient first. So always go ahead and, assess. Always use that. Assess, and then you can always do your ABCs as well. So you want to assess, check to see if there is something that is causing, the decrease in the output. All right, so reposition the tube and check for kinks. And once you realize that is good, then you can always go ahead and, alert your provider. So decreased NG tube with distension may indicate obstruction or displacement. So reposition is the safest first intervention. So irrigation is done per protocol with smaller amounts of fluid. All right, so always go ahead and assess. And then from there, when you assess, you figure more or less that everything is okay, then you can always, do additional things. Let your provider know, and then from there. All right. A nurse is caring for, and then because of the abdominal distension, once you have that kink, the air is not actually being released out of the stomach. All right, so you have that kink, so everything is backed up. So the patient is going to be just bloated. All right, so try to see if there's any kink, clear that up, and then from there you go. All right. A nurse is caring for a client with acute pancreatitis. Which laboratory finding is most specific to this condition? A, elevated ALT. B, elevated amylase and lipase. C, decreased albumin. D, increased bilirubin. So you have a patient that has acute pancreatitis. Which laboratory finding is most specific to this condition? A, elevated ALT. B, elevated amylase and lipase. C, decreased albumin. And D, increased bilirubin. So Asante says B, Melissa says B, Marlene says D. Okay. All right. So Marlene says D, increased bilirubin. What is bilirubin mostly associated with most of the time? What patients you tend to find that in? Marlene. Okay. Jaundice, yeah. Mm-hmm. All right. So, and liver problems, yeah. All right, so the amylase and the lipase is most associated with your pancreatitis. All right, their elevation is the most specific indicator of acute pancreatitis. ALT and bilirubin are more related to your liver and your gallbladder function. All right, so you have your pancreatitis that is associated with your amylase and your lipase, and your ALT and your bilirubin are more related to your liver and your gallbladder. All right. A client with, and which patient sometimes can you find your decreased albumin in? So patients you tend to find your albumin levels tend to be a little bit low in. Any patient that you tend to have like fluid shift in. All right. So sometimes you can find it in your CHFs. Sometimes your albumin level can be low. You have it liver, yes. All right. So those are some of the patients. A client with Crohn's disease is prescribed infliximab. The nurse should monitor for which of the serious side effects or adverse effect. All right, that's not a common, but so it is a immunosuppressant drug that let me give you the answers and then from there. All right, so a client with Crohn's disease is prescribed infliximab. The nurse should monitor for which of the most serious adverse effect. A, constipation. B, hypertension. C, infection. D, weight gain. So even if you never know this medication, which one of them would you think, is important for you in terms of this adverse effect that you want to be monitoring for? So A, constipation. B, hypertension. C, infection. D, weight gain. So the patient is a Crohn's patient and is prescribed infliximab. The nurse should monitor for which most serious adverse effects. So Asante says C, infection. Okay, do we have anybody else with anything else? Remember, you have the patient there. You have to choose one. You have to save the patient. All right. Yeah, the answer is actually C, infection. All right. So always try to see if you can use the process of elimination. Even if you don't know the content, when you're in the exam, just don't leave it blank. All right. Choose one of the answer. So if you have these four options here, constipation is not an adverse effect that we're super concerned about at any time, B, hypertension. D, weight gain. Usually that happens over time. You understand? So you'd be battling between B and C, hypertension and infection. And if you're going to look at any one of them that you'd be super concerned about, it would have been the infection. All right. But the medication infliximab is an immunosuppressant. So if you know the drug, then you'll be able to better, answer the question as well. It increases the risk of serious infection. So you want to go ahead and monitor for fever, cough and sore throat for this patient. All right. A client with esophageal varices is at risk for rupture. Which order should the nurse question? So you have a patient with esophageal varices. That patient is at risk for rupture. Which order would you question? A, administering propranolol. B, inserting an NG tube for lavage. C, providing stool softeners. D, monitor blood pressure frequently. So you have this patient and the doctor says, okay, then these are the orders. I want you to go ahead and, get it done. Which one would you question for the patient with esophageal varices? A, administering propranolol. B, inserting an NG tube for lavage. D, providing stool softeners. D, monitor blood pressure frequently. Asante says B. All right, do we have anybody else? I see 45 persons on the live. Please give me another answer. Melissa says C. Do we have anybody else? One more person. And Queen Susan says B. Thank you so much for tuning in and answering. All right, so Melissa, why did you say C? Why didn't you follow everybody else? Why you said C? So you said providing stool softener. Why you choose that one? So the answers were administer propranolol. C would have been provide stool softener. Insert NG tube for lavage. And D, monitor blood pressure frequently. And why did you say B, Queen Susan? So you said inserting an NG tube for lavage. The question was which one was questionable. Yes, which one was questionable? So the client has esophageal varices, is at risk for rupture. Which order would you question? A, the administering propranolol. B, inserting an NG tube for lavage. C would have been providing stool softener. And D, monitor blood pressure frequently. So, and it says irrigation. Okay. All right. So the answer is actually the B. All right. So this patient has esophageal varices, is at high risk for bleeding. All right. So you don't want to go ahead and cause any further trauma when you're inserting that NG tube, because the client normally need the NG tube. Yeah, they normally probably need the NG tube, but you have to remember that they have those varices there. So once you go ahead and insert that, NG tube down, then there's a high risk that you might just pop one of them. You might just cause further bleeding and cause, more problems for the patient. All right. So that's the one that you definitely will be questioning. So a lot of times, they might end up doing a procedure where they can actually use like an endoscopy and get that tube down if it is something that they definitely want. But you going blinded with, nothing to guide, then that is going to be a problem. All right. So you have to be very careful when you have these patients. All right. So the NG tube insertion can traumatize and rupture the varices, causing massive bleeding. And these are one of the patients, you definitely don't want to have, honestly. I've had one patient and I tell you, it take the entire night shift. You understand? We had to get this patient doing endoscopy at the bedside and everything. And I tell you, and then what made it worse is the patient was, morbidly obese. So it was very, very difficult. Very, very difficult. All right. Beta blockers reduce portal hypertension. Stool softeners prevent straining, and monitoring blood pressure is important. All right. So if you have the patient with esophageal varices, that patient is at risk for rupture. So definitely question your NG tube for your lavage. All right. A client is scheduled for colonoscopy. Which finding requires the nurse to notify the provider before the procedure? So you have a patient that is scheduled for colonoscopy. Which finding requires the nurse to notify the provider before the procedure? A, clear liquid diet for 24 hours. B, potassium of 2.9. C, polyethylene glycol prep completed. And D, NPO for 8 hours. So you have a patient that is going to be doing a colonoscopy. Which finding requires you to notify the provider before the procedure? A, clear liquid diet for 24 hours. B, potassium of 2.9. C, polyethylene glycol prep completed. And D, NPO for 8 hours. All right, Asante says B, Melissa says B. Nice. Potassium of 2.9. Why are you concerned about this patient that is, only going to be getting a colonoscopy? Why are you concerned about the patient's potassium? Okay, potassium is a lie. So why are you concerned about the patient's potassium that is 2.5, 2.9? Arrhythmias, yes, it's low. You're concerned about the arrhythmias. So definitely you want to make sure that we get that corrected before you put that patient to, be sedated. All right, so definitely address that. Clear liquid diet for 24 hours is pretty good, but polyethylene glycol prep is okay, all right, because you want to make sure you clear out all of that bowel so they can do their procedure and see everything that they're supposed to. NPO for 8 hours is also good. But the one that is, you definitely want to notify the provider is the potassium of 2.9. What is the normal potassium you're looking for this patient? What's the range you're working with? What's the normal level for reading for potassium? Remember to tap up the live. 3.5 to 5. Nice, definitely. All right. Which assessment finding indicates effective treatment? Which assessment finding indicates effective treatment of hepatic encephalopathy with lactulose? All right, so you have a patient that is diagnosed with hepatic encephalopathy and the patient is on lactulose. How do you know that it is, effective? A, decrease abdominal girth. B, increase urine output. C, decrease ammonia levels. D, improve appetite. So which assessment finding indicates effective treatment of hepatic encephalopathy with lactulose? A, decrease abdominal girth. B, increase urine output. C, decrease ammonia levels. And D, improve appetite. Nice. Your ammonia. Nice. Yes, tan fine. Ammonia. All right. So lactulose reduces ammonia absorption in the gut, improving mental status in hepatic encephalopathy patient. All right. Will this patient have decreased abdominal girth? Is their abdominal girth usually increase or decrease with a patient that has, your liver problems? Most of the time it's no. Okay, so usually it's the abdominal girth is decrease ammonia, improve appetite. Do they normally have good appetite? How's their appetite? Usually they're very picky. They really have no appetite. All right, and increase urine output. Sometimes their urine output is a little bit decreased and dark colored and all. All right. Yes. The nurse is caring for a client with peptic ulcer disease. Which symptom most likely indicates perforation? So you have a patient that has peptic ulcer disease. Which symptom most likely indicates perforation? A, epigastric burning after meals. B, black tarry stools. C, sudden severe abdominal pain and rigid abdomen. D, nausea and vomiting. So you have a patient with peptic ulcer disease. Which symptom most likely indicates perforation? A, epigastric burning after meals. B, black tarry stool. C, sudden severe abdominal pain and rigid abdomen. D, nausea and vomiting. So C, nice. All right, so sudden severe abdominal pain and rigid abdomen. All right, those are classic signs of perforation. And is it an emergency or is it something that, we can say, all right, let's prep this patient for surgery tomorrow? Is it something that is considered to be an emergency or not? Is it an emergency or it's It's an emergency, definitely. All right. Black tarry stool. Which patients tend to have black tarry stool? If you have a patient that has black tarry stool, what are you thinking about? I'm thinking about an ulcer. Okay. Anything else you're thinking about? If you have a patient that has a bleeding ulcer, definitely. All right, definitely. And the epigastric burning after meals also is the ulcer. Can be the GERD. All right. And nausea and vomiting can be related to a lot of things. All right. A client with ulcerative colitis is receiving total parenteral nutrition, TPN, which is the nurse's priority. A, monitor weekly, weight weekly. B, maintain strict asepsis when handling the central line. C, check the finger stick glucose once daily. D, maintain infusion rate if intake is poor. So you have a patient that has ulcerative colitis. The patient is receiving TPN, total parenteral nutrition, which is the nurse's priority. A, monitor weight weekly. B, maintain strict asepsis when handling the central line. C, check the finger stick glucose daily. And D, increase infusion rate if intake is poor. Jenny says B, which is maintain strict asepsis when handling central line. Shayna says D, increase infusion rate if intake is poor. All right. So, and we have Melissa says B, maintain strict asepsis when handling the central line. So definitely the priority there is to maintain your strict asepsis when handling the central line, because the patient is at greatest risk for your infection. So always think about your safety. All right, so use those as a part of how you go about and choose your answers for your exam. All right. So TPN requires central venous access, and infection sepsis is greatest risk for that patient. Nothing is wrong with monitoring your patient weight weekly, all right, because you want to make sure that the patient is gaining weight. All right. Checking glucose once a day is fine as well, because you want to make sure patient is getting, adequate amount of sugar intake. All right, and not going hypo. Increase infusion rate if intake is poor. The patient intake is poor, so that's why they're doing the TPN. All right, so you can always increase the rate depending on if you're not meeting the requirements in terms of your weight during the week, or depending on what is going on. You understand? If you realize the patient is not thriving well, then definitely they will go ahead and address that or adjust the rates. But maintaining your strict asepsis when handling the central line is most important, because this patient is at highest risk for your infection. All right. I remember which is the nurse's priority. So remember to look at the keywords in the question. All right. The nurse is providing discharge teaching to a client with cholecystectomy. And what procedure did they just had? So if somebody come and say, oh, I just had cholecystectomy, what are we talking about? What procedure did they just had? What organ did they, remove or got worked on? So if somebody comes up and say, oh, I just had a cholecystectomy, what organ did they remove? The intestines. Okay, C-section. Don't have a clue. Gallbladder. Okay. All right. So definitely gallbladder. All right. So if they come up and say, oh, I had cholecystectomy, most of the time they're talking about the gallbladder. All right, so the patient just had a gallbladder removal surgery. Which statement indicates understanding? A, I should eat a low-fat diet. B, I should avoid all carbohydrates. C, I should eat large meals to stimulate bile flow. D, I will take iron supplements daily. So the nurse is providing discharge teaching to a client with cholecystectomy. Which statement indicates understanding? A, I should eat a low-fat diet. B, I should avoid all carbohydrates. C, I should eat large meals to stimulate bile flow. And D, I will take iron supplements daily. AAA, nice. I should eat a low-fat diet. Why you don't want him to be eating a high-fat diet? Huh? Because of multiple different reasons. All right, but you want to make sure they're eating a low-fat diet because they don't want their gallbladder, their fat to be, well, the gallbladder is supposed to be helping with the fat, you know. Gallbladder is removed, yeah. The gallbladder is to help with, you know, the fat that breakdown. And so it's already, you know, removed. So you don't have anything that is there to help with that. So you definitely want them to be eating foods that are very low in fat to prevent that. All right. I should avoid all carbohydrates. Should they avoid all carbohydrates? Who you'd want to cut down your carbohydrates on? Which patients would you, you know, tell to cut down on their carbohydrates? Who do you want to cut down your carbohydrates on? A lot of us need our carbohydrates cut down. Cushion's, diabetics, okay. You're diabetic, yes. I should eat large meals to stimulate bile flow. I will take iron supplements daily. Who you'd encourage, you know, to take their iron supplements daily? Which patient would be saying that to you? Yeah, anemic patients, yeah. All right, so after gallbladder removal, fat digestion may be impaired. Low fat meals reduce GI distress. Personalities, anemia, anemic. Okay, anemic patient, definitely. All right. A client is admitted with suspected bowel obstruction. Which finding is most concerning? A visible peristaltic wave. B, high-pitched bowel sounds. C, continuous pain with guarding. D, abdominal distension. All right, so a client is admitted with suspected bowel obstruction. Which finding is most concerning? A, visible peristaltic waves. B, high-pitched bowel sounds. C, continuous pain with guarding. D, abdominal distension. So Asante says C, continuous pain and guarding. Okay. Do we have anybody else? C, Jenny. Okay. And one more person. I have 35 persons here. One more person. So you have a patient that is admitted with suspected bowel obstruction. Which finding is most concerning? A, visible peristaltic waves. B, high-pitched bowel sounds. C, continuous pain with guarding. And D, abdominal distension. And Shayna says C, continuous pain with guarding. What are you thinking about? So if the patient has bowel obstruction, patient is having the continuous pain and the guarding, what are you thinking about in terms of what's happening? You're thinking about peritonitis. Okay, nice, Shayna. Yes. So yes, the patient has bowel obstruction. So the patient is going to have some perforation. Yes. So when you're concerned about peritonitis, the strangulation there with the bowels. So definitely you want to make sure that, you know, you find a provider so you can go ahead and prep this patient for surgery and then from there. All right. So continuous pain and guarding suggests peritonitis or strangulation, which is life-threatening. So definitely you want to go ahead, keep a patient NPO, make sure they have their IV, you know, get consent if that wasn't done from before, and all of those things. You understand? Just get a patient prepped for surgery. All right. High-pitched bowel sounds. Would you have high-pitched bowel sounds in these patients? So the patient has bowel obstruction. Would you have high-pitch, low-pitch? What kind of sounds you're expecting to hear for the patient with bowel obstruction? Hypoactive bowel sounds. So it would be hypoactive asante. It will be low. All right. Then they would have the abdominal distension, the visible peristaltic waves. The visible peristaltic waves, who is that a lot of times associated with? Let me tell you. Who normally has visible peristaltic waves? What patients? So the same one. So you have it in the intestinal. Okay, so the pyloric stenosis, that's the one I was thinking. All right, so you can have the peristaltic waves, the visible peristaltic waves in patients with your intestinal obstructions. You have pyloric stenosis, diverticular disease, you have strictures, and any presence of foreign body. Yeah, but pyloric stenosis tend to have that when it comes on to the infants. All right, as well. The nurse prepares to administer sucralfate. When should it be given for maximum effect? So is it with meals? Is it with meals, after meals, at bedtime on an empty stomach, or at any time? So a nurse prepares to administer sucralfate. When should it be given for maximum effectiveness? With meals, after meals, at bedtime, on an empty stomach, at any time. On an empty stomach. Anybody else? And why you want to give it on an empty stomach, Asante? The nurse prepares to administer sucralfate. When should it be given for maximum effectiveness? A, with meals. B, after meals, at bedtime, and on an empty stomach. D, at any time. All right, and so who was it again? I said Asante on an empty stomach. Yes, so it's given on an empty stomach. It is used to help to coat this ulcer and also absorption to prevent pain before meals. Okay, so yes, you want to give it on an empty stomach before meals. All right, at least 1 to 2 hours before meals. All right. All right. So I think we had done that part. Hold on. Okay. A nurse must prioritize assignment. All right. Which patient should the RN care for? A post-op cholecystectomy with nausea control and stable vital signs. B, a GI client with a GI bleed with drop-in hemoglobin and tachycardia. C, chronic GERD patient needing discharge teaching. D, a stable patient with who is receiving outpatient endoscopy. So a nurse must prioritize assignment. Which patient should the RN care for? A post-op cholecystectomy with nausea controlled and stable vital signs. B, a GI patient with the drop-in hemoglobin and tachycardia. C, chronic GERD patient needing discharge teaching. and a stable patient receiving outpatient endoscopy. So I have B, B. Okay, so definitely, why are you concerned about B? Why would you keep that patient and not give it to someone else? Why wouldn't you assign the patient to someone else? The patient with the GI bleed that is dropping hemoglobin and tachycardia. Why you want to hold on to that patient as the RN? The patient is unstable, all right? The patient is unstable. So what are some things that you can do for this patient in the meantime? So you have this patient that is unstable. What are some things that you definitely need to have for this patient going? What are you anticipating in terms of, you know, the orders? Can't just list them out. All right, I'll start. IV. I want to make sure you have 2 large bore IVs. What are some other things you're anticipating? Folus position and oxygen. What else are you anticipating? So this patient, GI bleed, dropping hemoglobin, tachycardia. What else can you be doing or you're anticipating? So apart from the IV, anything else we want to do? And the I-folus position, vital signs, okay. How often will you be doing this vital signs? Every 4 hours, every 6 hours? How often you're anticipating? 15 minutes, 30 minutes. Cardiac monitoring. You have your IV, cardiac monitor. You're doing your vitals like every 15 minutes. All right. What about, are you thinking about getting a type and screen for this patient? In the meantime, blood transfusion by doctor's orders. Okay, but in the meantime, we can go ahead and, you know, consent the patient for, you know, blood transfusion. All right, because we know that the patient is tachycardic and the hemoglobin is low. All right. Would you be giving this patient any fluid in the meantime? Patient is tachycardic. Would you be trying to give this fluid patient some fluid in the meantime? Would this patient be NPO or eating? I know it's a silly question. Yes, we'll be giving fluids. So you'll be NPO in this patient. All right. Would you be putting in an NG tube on this patient? Would you be thinking about an NG tube for this patient? Santi says no.
Mommy, can I talk with you while we're talking?
Would you be thinking about an NG tube for this patient with a GI bleed? So Asante says no. Do we have anybody else? Why you not be thinking about an NG tube for this patient, Asante? Shayna says yes. Okay. So definitely you'll be thinking about, as long as the patient don't have, what is one thing you're thinking about that would be contraindicated, might be required based on location. Yes, it might be. That's what I was gonna ask. I was gonna ask a while ago. So what is one thing that I think we should because of the bleeding? Yes. So we will get an NG tube in this patient. All right. And but what if the patient has a history of esophageal varices? Would you be, you know, popping in that NG tube? No, no. All right. Definitely not. So just make sure you document that, you know, or let the provider know that this patient has a history of, you know, esophageal varices. And then from there, they can either take the patient to the OR, get the NG tube in at that time, you know, if it is really needed. But otherwise, you know, those are some things that you definitely want to do. But this patient would have been unstable. So you, the primary nurse, would take responsibility for this patient. The other patients, the post-op cholecystectomy patient with nausea controlled and stable vital signs, who will you be giving that patient to? So, you know, it's a post-op. If it's going to be the initial, If it's going to be the initial, when the patient just came out of surgery, then definitely that's going to be yours as well if you don't have another RN. All right. You can't delegate that patient to the LPN because you're going to have to do the initial assessment on this post-op patient. If the patient has been out for a little bit and you're going to be doing reassessments and all, then definitely that patient could be assigned too because of the word stable. All right, so the patient is stable, the nausea is controlled, then you probably could delegate that patient to the LPN. All right, chronic GERD patient needing discharge teaching. Even though it's chronic GERD and the patient is going home, if it is going to be the initial teaching, then that's going to be the primary responsibility of the nurse. All right, so even though this patient is like through the door, that's going to be your responsibility as, the RN. If it's only 2 persons there, you and the LPN. All right, stable patient receiving outpatient endoscopy definitely can be assigned to the LPN. All right, so the other 3 patients are going to be yours. But if you're supposed to give up, if you're supposed to choose one, then the GI bleed is going to be priority. And then, if there's another nurse, you can always say, okay, then these are yours. All right, but the only one that you can give is D to the LPN. The others are going to be to the RN. And you're prioritizing the GI patient there. All right. In a facility outbreak of, this one. A client with acute pancreatitis is NPO and has an NG tube on suction. Which statement, sorry, 1 minute. All right, sorry. All right, so a client with acute pancreatitis is NPO and has an NG tube to suction. Which safety measure is highest priority? A, tape the tube to the nose securely and check placement before irrigation. B, offer ice chips when patient requests. C, encourage coughing and deep breathing only hourly. D, remove the suction at night to allow sleep. So you have a client with acute pancreatitis who is NPO and has an NG tube to suction. Which safety measure is highest priority? A, tape the tube to the nose securely and check placement before irrigation. B, offer ice chips when patient requests. C, encourage coughing and deep breathing only hourly. D, remove suction at night to allow sleep. A. Nice. So A, tape the tube to the nose securely and check placement before irrigation. All right, so the tape the tube, so prevent inadvertent tube removal, aspiration, and ensure proper function. All right. So how would you know that this tube is actually in the stomach? How would you, so when you check, what are you looking for? How would you go about with checking to see that this tube is in the stomach? What are some things that you can do? So you have this patient to feed, not this one, but yes, you can aspirate. And when you aspirate, what are you looking for? Aspirate, x-ray, okay. You can check the pH as well. Nice, yes. All right. And you're looking for the stomach fluid. All right. And then depending on, some patients, depending on what they're eating, sometimes if you pull back and you see, you'll see undigested food, you'll definitely know that you're in the stomach. So for example, we're not talking about this patient that has pancreatitis. Let's just use a stethoscope and listen for that whooshing sound. Definitely. So there, you have this patient that you're supposed to feed, not this NPO patient here. All right. You have a patient that you're supposed to be feeding. How would you know it's how much fluid are you expecting? Like stomach content are you expecting to pull back to say whether or not, this patient is okay to feed or not? what are you looking at in terms of the amount of mils of stomach content? So, for example, you're pulling back and you get 60 mils. Would you still go ahead and feel less than 150? Okay. All right. So I think it's, yeah. So anything between, I think it's like, I was looking for 60 and 150, but anything less than 150, you should be all set with, making sure you can feed that patient. All right. But you don't want to be having too much because then the patient is not absorbing. So you don't want to go ahead and give the patient too much. So always go ahead and pull back. A lot of times we don't really do most of that. Honestly, a lot of times we don't really do it, but that is the right thing, especially if the patient has it in for a long time and you're going to be feeding them. All right. So it shouldn't be much that they have. All right. Offer ice chips when patient requests. So this patient has an NG tube in, pull back, do you discard? Pull back, do you discard? No, you put it back in. You're just pulling up in the big syringe. Yeah. All right. So if you're pulling up and you pull up too much, because you have the big syringe, so you should be pulling up in the syringe. Should be pulling up in that syringe, but if you're pulling up and there's just too much, because then you'll be able to see the amount that you're pulling up, you just put it back in. If it's a case where you realize that, you're supposed to be feeding the patient, just like, sometimes you have colic, you can always take it out and discard it, especially if you realize that, the patient is not absorbing it. Then you can always just pull it out and discard it. All right. Because if you feed the patient like, 4 hours ago and the patient still has like a ton of, fluid there and it's not going anywhere, then usually sometimes, it stay there and get sour. So it will cause a patient to start vomit and everything. So if it is, more than the amount and it's been there for, the 4 hours or more, go ahead and just, especially if they start vomiting. Most of the time, the stomach content is just sour. All right, so just like how you become nauseous because of something that you eat, is the same thing. It just stays in the stomach and then it makes them, get nauseous and then start vomiting. So you just pull it out and waste it. All right. So the patient is asking for ice chips. Would you give this patient ice chips? The patient has an NG tube, so whatever this, they drink, it's gonna be coming back out of that tube. Would you go ahead and give this patient ice chips? So the patient, this acute pancreatitis patient is NPO, and the patient has an NG tube on suction. Would you give this patient ice chips because they asked for it and because, they already have the NG tube? It's actually going to be suction out. So would you give them? So Asante says no. Okay. Yes, I wouldn't give them either. You understand? Because you want the stomach to be empty, you don't want to be introducing anything into the stomach. So I would definitely not give them anything. Just like some persons, they have, they're of the mindset that because you're putting in the NG tube and it's going to be draining, it's okay for them to be sucking or drinking water, sipping water while you're inserting that NG tube. I don't do that one either. All right, I don't do that one either. Not because it's going in. Doesn't necessarily mean that all the time it comes back out. Because sometimes you put in NG tube and nothing coming out of it. So I don't do that. I prefer them just suck on a straw or something. But they're not sucking on any fluid to introduce in there and then give me more work to do. You know them way there? But it's not necessarily a amount of work. But in terms of for the safety of the patient, I just feel as though I wouldn't want to introduce anything else to them. All right. Sorry. All right. Encourage coughing and deep breathing only hourly. Only hourly? Nah. And remove suction at night to allow sleep. So for example, the patient say, Well, nurse, you know that at night I just want to sleep. Would you discontinue the suction and just, let them go to sleep, or what would you do? Would it be on intermittent? Would it be on continuous? Sorry. Yes, so no, it will be on intermittent suctioning, low suctioning, and that's it. But there's no turn off suctioning, and yeah, because during that time period, there is fluid that is being built up. So you still want to get out that's fluid out of the stomach. So keep them on intermittent suction, sleeping, awake, and that's the end of it. All right. A nurse received conflicting orders for TPN. What should the nurse do? So the nurse received conflicting orders for TPN rate. What should the nurse do? A, hold the TPN and clarify with the prescriber before change. B, increase the rate to make up deficit. C, decrease the rate and document rational. D, continue current rate and ignore the new order. So you have a patient that has TPN, total parenteral nutrition, and the orders are conflicting. What will you do? All right. Hey, Lily, welcome. So AA, which says hold the TPN and clarify with the prescriber before change is the correct thing to do. All right. So TPN changes affects glucose and electrolytes. So you definitely want to make sure you check with them, clarify with them before. All right. Increase rate to make up deficits is, you don't want to do that. All right. Decrease the rate and document the rationale. No, the rate can only be decreased by the provider. All right. So you have to do according to the order. So you can't just go ahead and decrease the rate because you feel as though, the order is inaccurate. The best thing to do is hold off on it and then get the new orders or clarify, with the provider regarding the change. And then continue current rate and ignore new order. No, you don't want to do that. All right. Make sure you're looking out for the safety of the patient. All right. When preparing a patient for emergency endoscopy for GI bleed, which consent nuance is critical? A, oral consent from family only. B, document what procedure may require sedation and blood products. C, consent is not needed in any emergent endoscopy. D, witness signature is optional. So when preparing a patient for endoscopy, emergent endoscopy for GI bleed, which consent nuance is critical? A, oral consent from family only. B, document that procedure may require sedation and blood products. C, consent is not needed in emergency endoscopy. And D, witness signature is optional. So Shell says A, oral consent from family only. B is Melissa. Document that procedure may require sedation and products. So Shell changes her mind and said she thinks it's B. Lady Mal says A, oral consent from family members. All right. So remember, when it comes down to your consents, all right, document that the procedure may require sedation and products and blood products. That's the one that is the answer here. All right. Patient must be always, be informed of the risk. All right. They must be informed of the risk as well as the sedation itself that are they're going to be using. So always talk about, the sedation, the risk that are possible. So document that procedure may require sedation and blood products is the answer. So when preparing a patient for emergent endoscopy for GI bleed, which consent nuance is critical? Documenting that that the procedure may require sedation and blood products. And this is because patients must be informed of sedation/risk when possible. All right. Oral consent from family members only. Not all the time you're gonna always get the consent from the family member. All right, you can still get consent from the patient as well. Consent is not needed in any emergent endoscopy. You still need some form of consent. All right, you still need some consent there, whether from the patient or from the family members. If it's not, If it's something that is a dire emergency and you can't get it from them, then the provider will always go ahead and, you know, make that decision. Witness signature is optional. You know, you're always gonna either find either the nurse, somebody is gonna be there witnessing with the provider as well. So there's always gonna have like 2 signatures on that paper when they're doing anything that is emergency as well. All right, so document that the procedure may require sedation and blood products. The patient must be informed of sedation / risk when possible. All right. A client with a nurse delegates feeding via gastrostomy to a CNA. Which task requires the RN, not delegation? So a nurse delegates feeding via gastrostomy to a CNA. Which task requires the RN, not delegation? A, check-in placement via X-ray review. B, warming formula to room temperature. C, assisting client to upright position. D, cleaning external tube site after feed. So a nurse delegates feeding via gastrostomy to a CNA. Which task requires the RN, not delegation? A, checking placement via X-ray review. B, warming formula to room temperature. C, assisting client to upright position. D, cleaning external tube site after feed. A, checking placement of X-ray via X-ray review. All right. So assessment and interpretation are RN responsibility at all times. So the CNA can warm the formula. They can also assist the client in an upright position and clean the external tube site as well. All right. A patient with vomiting and NG tube has electrolyte labs. Which imbalances are expected? So you have a patient that has been vomiting, and the patient also has an NG tube. Their electrolytes has been resulted. Which imbalances are expected? Is it A, hypokalemia and metabolic acidosis? Well, alkalosis. B, hyperkalemia and metabolic acidosis. C, hyponatremia and respiratory alkalosis. D, hypernatremia and metabolic acidosis. So you have a patient with vomiting and NG tube that has electrolyte labs. Which imbalances are expected? A, hypokalemia with a K and metabolic alkalosis. B, hyperkalemia with a K and metabolic acidosis. C, hyponatremia and respiratory alkalosis. Or D, hypernatremia and metabolic acidosis. So which patient electrolyte imbalances or lab results you choose here to represent that patient? The patient is vomiting and the patient also has an NG tube. So Melissa says A. Do we have anybody else with another option or with the same? Shells is blessed says D, hypernatremia and metabolic acidosis. All right, so I guess if we, you know, we'll try to say we can do one of those ABG classes. It's a D, Nita says D, hypernatremia and metabolic acidosis. So the patient that has vomiting and NG tube, carousel, okay, so D. So a patient with vomiting and NG tube has electrolyte labs. Which imbalances are expected? A, hypokalemia and metabolic alkalosis. B, hyperkalemia and metabolic acidosis. C, hyponatremia and respiratory alkalosis. D, hypernatremia and metabolic acidosis. All right. So which of those will that patient lab value show? Carousel says A. All right, so yes, so anyone that says a hypokalemia with a K, a metabolic alkalosis, then you're correct on that one. All right, because remember, you know, you have gastric loss of your hydrochloric acid. All right, your hydrogen ions, potassium as well, vomiting. So the patient is gonna be in alkalosis. All right, and most of the time when you have the vomiting, the diarrhea, that patient is in metabolic alkalosis. And when you start doing ABGs, you know, acid-base balance, you'll realize that you'll eventually know which one is, you know, alkalosis and which one is in the metabolic, all right, based on all of that. And then this patient is also at risk for your hypokalemia because of the loss of the potassium as well. So gastric loss of hydrogen and potassium causes alkalosis and hypokalemia. For a patient that is diabetic, what imbalance would you think they are having? So you have a patient that is in DKA. What would their acid-base balance look like? Would they be in like metabolic acidosis, respiratory acidosis, or metabolic alkalosis, or which one would you be thinking for a diabetic patient, a DKA patient? Metabolic alkalosis. Do you have anybody else with another one? So if a DKA patient, what would that patient be in? Would it be metabolic alkalosis, metabolic acidosis, respiratory alkalosis, or respiratory alkalosis, metabolic acidosis? Yeah, so that patient is acidotic, Melissa. All right. So that patient is going to be in metabolic acidosis. All right. All right. For patient with ascites, which is the most appropriate to reduce discomfort? So a patient that has ascites, which one would be most appropriate to reduce discomfort? A, elevate the head and assist with mobilization and positioning. B, encourage high sodium meals. C, ambulate only after paracentesis. D, avoid abdominal binder use always. So patient with ascites, you have a patient with ascites, which is the most appropriate to reduce discomfort? A, elevate head and assist with mobilization and positioning. B, encourage high sodium meals. C, ambulate only after paracentesis. D, avoid abdominal binder use always. So I want to try to make this patient, you know, comfortable. What are you going to be doing? Melissa says A. Okay. So A is elevate head and assist with mobilization and positioning. A. Yes. So that's the answer. All right. So elevate head and assist with mobilization comfort. Measures and mobility reduce respiratory compromise there. Ambulate only after paracentesis. Is it only after paracentesis? You would encourage ambulation for these patients. All right. A lot of times, once they have the paracentesis where they drain, you know, the fluid from the abdomen, they can go back and walk, you know, in a couple of hours. You know, some persons are up sitting because they feel so much better because they don't have that distension there anymore. So a lot of times they feel like, you know, they want to go ahead and just ambulate. But it's not only after paracentesis. Avoid abdominal binder use always. No, a lot of times patients tend to help, you know, use that when they have the fluid there. But sometimes they don't like it because it impedes their breathing as well. All right, so no. A post-op patient following bowel resection as an epidural infusion for pain. Which is priority assessment? So you have a post-op patient following bowel resection as an epidural infusion for pain. Which is priority assessment for this patient? A, respiratory rate and sedation level. B, bowel sounds only. C, capillary refill in toes only. D, site of incision only. So you have a post-op patient following bowel resection who has an epidural infusion for pain. Which priority assessment is important? A, respiratory rate and sedation. B, bowel sounds only. C, capillary refill in toes only. Or D, site of incision only. All right, so Nina says A, Carousel says A. Do we have another person who want to say something else or something similar? And Lily says A, definitely. Why are you guys concerned about the respiratory rate and the sedation level and this patient had a bowel resection? It's only a bowel resection now. Why are you concerned about that? Why are you concerned about the respiratory rate and sedation level for this patient? Why are you concerned about the respiratory rate and the sedation for this patient? Because they mostly use opioid analgesics. Yes, so this patient is at high risk, yes, because of the epidural pain insertion. So because of the epidural pain insertion. Okay, so because of the medication that they're using, that patient is going to be at risk for respiratory depression. All right. So you want to make sure that you're monitoring the respiratory rate and the sedation level for this patient. So for example, you go and you realize that this patient, you were supposed to start this patient on the medication. The respiratory rate was like, say, 8, 9, and the patient had a morphine order. Would you go ahead and start this morphine because the patient is like, oh my God, nurse, I'm having so much pain. I need that pain medication. Would you go ahead and give that medication to the patient? No. All right. No. You will withhold it. What if you did go ahead and give the patient the morphine and the patient, respiratory rate is very low? What would you go ahead and try to help with? What medication would you be thinking about to try and reverse that? You go ahead and the patient is already on the patient is on the morphine and you realize the patient, respiratory rate is like 8, then it's going down to 6. What would you go ahead and try grabbing to get that corrected? The Narcan, definitely. All right, you definitely go ahead and get your Narcan for that opiate overdose. All right. Which other one? So post-op client, bowel sounds only. No, you want to be checking only the bowel sounds. All right. Usually only answer. Exactly. So that's what I was gonna go at. So the bowel sounds only. Never choose the only. Anytime you see a question or answer that says only, try to avoid that answer. All right. There are so many other things that you can be doing in the meantime. So bowel sounds only. That's not the only thing you're gonna be checking. All right. You're going to check the site as well. You're going to check capillary refill, all of those things, mental status, all of those things. So all of these that says bowel sounds only, capillary refill in toes only, site of infusion only, just mark those off, all right? Use the process of elimination, get those out of the way. So even if you never know about, bowel resection as well as epidural, infusion for pain, at least that's the only answer there that is like standing. Because definitely that when I'm doing assessment, I'm not only listening to bowel sounds. When I'm doing assessment, I'm not just checking for capillary refill. There's so many other things you're doing. So eliminate those, and then from there you're left with your answer. All right. So respiratory rate and sedation level, you'll check that. Epidural opioids, analgesics can depress your respiratory rate. All right. A patient with pancreatitis reports severe pain, 10 out of 10. Which intervention is best? A, frequent IV opioid analgesic or administration per protocol and positioning leaning forward. B, offer oral analgesics PRN. C, encourage ambulation immediately. D, provide heating pad directly to the abdomen. So a patient with pancreatitis reports severe pain, 10 out of 10. Which intervention is best? A, frequent IV opioid analgesic administration per protocol and positioning leaning forward. B, offer oral analgesics PRN. C, encourage ambulation immediately. D, provide heating pad directly to the abdomen. Which answer would you say? Carousel says A. Elizabeth says A. Frequent IV opioid administration per protocol and positioning leaning forward. One Braille says A. Okay, nice. All right. So that's the answer. The IV opioid and positioning leaning forward. So severe visceral pain response to IV analgesia and supportive positioning. All right. Why wouldn't you offer this patient oral analgesics? Patient, why you wouldn't want to give this patient the oral analgesic? Would this patient be taking anything by mouth? So this patient has pancreatitis. Would you give anything by mouth to this patient? So no, you wouldn't be giving this patient anything by mouth with a mouth. All right. So this patient would be NPO. All right. So offering oral analgesics PRN is definitely out of it. All right. Encourage ambulation immediately. No, that patient is in a lot of pain. All right. The patient is in so much pain. So you want to be having that patient be, walking around and doing everything. Provide heating pad directly to the abdomen. Would you be providing, heating pad to the abdomen for this patient? NPO plus choose the fastest route for administering medications. Nice, Nita. Yeah, so with the NPO, it's going to take you a few hours before the patient gets relief with this. So you want to go with anything that is going to be, the quickest way to, the bloodstream, which would have been the IV. All right. Providing heating pad directly to the abdomen. Would you be doing that? I wouldn't be providing any heating pad to the abdomen, yeah, I want to do that. I think probably you could, but I wouldn't be doing that, the heating pad. All right. With this patient with pancreatitis, would you be concerned about, the glucose on this patient? Which direction are you thinking it's going to be going? Is it going to be high or low? Carousel, this is not an answer for you. Nor Melissa, this is not an answer for you. A question for you. All right. So I need somebody else to answer. So this patient has pancreatitis. Would you expect the glucose to be high or low? Would you be concerned about the glucose for this patient? I see 34. It's going to be high. It's going to be high. It's going to be high. Why it's going to be high? All right. So everybody's saying high. Carousel, you want to answer? Melissa, you want to answer? It's going to be up, up. Everybody is up, up. What do you say about this question, Carousel, Melissa? All right, because the pancreas is not able to produce insulin. I got it wrong. Okay. All right, so it's going to be high, high, high. So we have high, high, high. Elevated glucose. Okay, so you definitely want to go ahead and keep this patient NPO. You want to keep an eye on this patient's glucose as well because of pancreas. All right. So hold on there, because I thought this patient would have been hypo. The patient would be hypoglycemic. All right. So this patient is going to be at risk for hypoglycemia. Let's look it up. So this patient is gonna be at risk for hypoglycemia. I thought the last time you had said the pancreas produces insulin. Yes, because the patient's NPO status. Okay. So one of the complications for pancreatitis is hypoglycemia. All right, because remember, the pancreas is in pancreatitis, you have damage to the cells that produces glucagon, a hormone that raises blood sugar glucose. All right, so you might have insulin In some cases, pancreatitis can lead to overproduction of insulin, a hormone that lowers your blood sugar levels there. So you might have insulinomia as well. So you definitely want to go ahead and monitor the patient's, glucose. So the patient is at risk for hypoglycemia. All right. So that is one of the serious complications of pancreatitis that you need to be looking at. Patients with pancreatitis should be monitored for blood sugar levels and receive treatment if necessary. If you experience the symptoms of so hypoglycemia, the patient would be at risk for. I thought the last time you had answered hypoglycemia, so I was waiting for you. So remember, the pancreas is already damaged. All right, the pancreas is damaged, so you're gonna have issues with the glucose there. All right. Because you don't have that hormone there. It's not producing that hormone, the glucagon there. All right, so that's the answer. But yeah. Then what I read somewhere was wrong. Okay. Yeah, I know that because you have the damage there, the patient is going to be at risk for hypoglycemia. So you have to keep an eye on that. All right. So just look it up again and then from there. All right. So let's go. Okay. A patient has an ileostomy and watery output. It's gonna be hypoglycemia. So the patient is at risk for hypoglycemia. That is one of the serious complications. So with pancreatitis, you have the pancreas not able to produce that glucagon. All right. So you're gonna have that patient being hypoglycemic. So you have to keep an eye on their glucose level. And you need that glucagon to increase your glucose. So if you're not producing it, then the glucose is just going to be dropping. You're not going to have anything there released or being produced. All right. All right. So you have a patient that has an ileostomy and watery output. Which instruction prevents skin breakdown? So you have a patient that has ileostomy and watery output. Which instruction prevents skin breakdown? A, change the pouch promptly when leakage is observed and protect the skin with barrier paste. B, wipe with alcohol only. C, leave appliance unemptied for 24 hours. D, use adhesive remover sparingly, never use barrier. So I have a patient that has ileostomy and watery output. Which instruction prevents skin breakdown? A, change the pouch promptly when leakage is observed and protect the skin with barrier paste. B, wipe with alcohol only. C, leave appliance unemptied for 24 hours. Or D, use adhesive remover sparingly, never use barrier. So A. Okay, nice. All right. So stool enzyme causes excoriation. Barriers protect peristomal skin. All right. So you always want to go ahead and, use a little barrier cream there. All right. Wipe with alcohol only. As I say, always look at the answer. And if it says only, then that just eliminate that. All right. Just eliminate it. But can you use the alcohol? A lot of persons I think I've seen a few persons that use the alcohol to clean, to wipe the area there. I've seen a few persons who've used it. Leave the appliance unemptied for 24 hours. Use adhesive remover sparingly, never use barrier. As I say, so you barriers protect peristomal skin, and you do the stool enzymes. You see where it says the stool enzymes causes excoriation. So definitely go ahead and use your barrier cream whenever you're changing. All right. So as soon as you start seeing it leaking, just go ahead and change it. All right. A patient with pancreatitis on NPO status complains of thirst. Best nursing action for this patient. Doesn't alcohol. Alcohol cause irritation, but some people will tell you that sometimes depending on, you know, the skin there. I think they say it dries it up. Some people say it dry up. I don't know, but I don't really use it. I don't use it. So I was like, you know, but then with the answer there only, you can use the alcohol with other things. All right. But it causes irritation, so it depends on what stage of, you know, the healing process you're at with that. But I do see a lot of persons will use, like, you know, the alcohol there, and I think with the alcohol as well, it helps with removing that glue on the skin as well. All right. So a patient with pancreatitis on NPO status complains of thirst. Best nursing action is A, offer oral hygiene and lip balm frequently. B, hi Ellis. Let me stop. Hi Sir Ellis, how are you doing? Shane. A patient with pancreatitis on NPO status complains of thirst. The best nursing action is A, offer oral hygiene and lip balm frequently. B, permit sips of water without checking order. C, give ice chips immediately. D, ignore the complaint. So you have a patient with pancreatitis on NPO status complaining of thirst. What is the best nursing action? A, or offer oral hygiene and lip balm frequently. B, permit sips of water without checking the order. C, give ice chips immediately. And D, ignore the complaint. Thank you, Shane.
Hello. Can I hug you?
Sure. Put you on the camera. Yeah, on the camera. Go to your bed. Go to your bed. All right. So which of them is the best nursing action? So you have a patient that is NPO. The patient is also, you know, having a diagnosis of pancreatitis, or they're having a pancreatitis attack. All right. The patient is complaining of thirst. What is the best nursing action for you? Is it A, offer sips of water and lip balm? No, offer oral hygiene and lip balm frequently. B, permit sips of water without checking order. C, give ice chips immediately. Or D, ignore the patient complaint. So Lily says A, definitely offer oral hygiene and lip balm frequently. All right. Oral care alleviates thirst while maintaining NPO. So you can always, you know, go ahead and do your mouth care. Tell them just don't swallow. And sometimes you can't even trust some of the patients then with mouth care, you know, because the patient will end up and swallow. Oh Lord. Yeah, they will go ahead and swallow the water. You understand? So don't trust them that well. Give them the little sponge and tell them, you know, go ahead and just wipe out in the corner of your mouth. Keep it moist. But if you think you can't trust the patient, then fine. But sometimes you can't really trust them that well with the water. Because when you say that, you know, you're thirsty, yeah, man, just imagine those patients having their little thing going on. They haven't eaten or you know, drank anything for days because they're having this pancreat here gulp. I tell you, yeah, they're having their attack for, you know, for days, and they're NPO, and they say they want something to rinse their mouth, and you go give them, especially when you tell them, say, oh, it's just some ice water, just go ahead and rinse your mouth. Them just drink it. Them not care. You understand? Because I'm thirsty. They're so thirsty, so don't trust them with it. All right, but don't give them ice chips. Do not ignore the complaint. Do not give them small sips of water. All right. Make sure you go ahead and offer them oral hygiene and a lip balm. All right. Sometimes you can give them, as I say, you have the little sponge that you can give them. You wet it and you just leave it at their bedside. So if it means you're going to leave at least 5 with them, give them that so they don't have to be like sucking on the same sponge for the entire day. You know, give them a few and they'll just, you know, wet it and just kind of dab their mouth with it. All right. A client with GERD uses PPI rather. When is the best time to take it? What's PPI? What's PPI? So if you have a patient that is on PPI and somebody asks you, what is PPI? I don't know what is PPI. What is PPI for you? As it relates to the GI system. Hi, Life Shines. How are you? So I have a patient that is that has GERD, and the patient is on PPI. What medication are we talking? What are we talking about here? Your proton pump inhibitors. All right. So proton pump inhibitors. So a client with GERD uses PPI, which is proton pump inhibitor. When is the best time to take the medication? A, 30 to 60 minutes before breakfast. B, before bedtime only. C, with the largest meal of the day. D, on an empty stomach. So you have a patient that has GERD. He's using a PPI. When is the best time to take the medication? A, 30 to 60 minutes before breakfast. B, before bedtime only. C, with the largest meal of the day. Or D, on an empty stomach at noon. All right, so we have A, 30 minutes before breakfast. Why you want the patient to take it at that time? Why 30 minutes before breakfast? Why the patient can't just take it at noon? Whatever patient is, you know. Yeah, why you have to tell the patient to take it before breakfast? To coat the stomach. Okay, all right. So at that time, you know, you have the production of your acid at that time. So definitely you want to make sure before they start eating anything, the start of the day, you take that medication to help with blocking that acid production there. All right. So 30 to 60 minutes before breakfast, PPIs work best when taken before meals to block stimulated acid production. Give me one or two of the most common PPIs you're thinking about that you tend to hear patients be taking or you be taking. Yeah, name 2 PPIs that you can think of. Omeprazole, okay. Anything else? Pantoprazole, nice. All right, lansoprazole, good. All right, so always tell the patient 30 to 60 minutes before breakfast, they should be all set with taking that medication. All right. A patient with hepatic encephalopathy is confused and at risk for aspiration. Prior nursing intervention includes what? A, keep the patient NPO, maintain safe airway, and use aspiration precautions. B, encourage frequent oral intake. C, allow independent eating only. D, avoid suctioning even if needed. So you have a patient with hepatic encephalopathy. Which patient is at risk for this? So which patient is at risk for hepatic encephalopathy? So which patients are at risk for your hepatic encephalopathy? Or older adults, okay. Or which organ is being affected? The liver, okay. And which condition that, what are 2 conditions? Okay, the liver. Give me 2 conditions that you're thinking about that is at highest risk for, you know, hepatic encephalopathy. Your cirrhosis, your alcoholics. All right. So a patient with hepatic encephalopathy is alcoholism. Uh-huh. The same damage to your liver. So they're gonna be at risk for that. Mm-hmm. All right, so a patient with hepatic encephalopathy is confused and at risk for aspiration. Prior nursing intervention includes A, keep patient NPO, maintain safe airway, and use aspiration precautions. B, encourage frequent oral intake. C, allow independent eating only. D, avoid suctioning even if needed. So which is the best answer? A, okay. We have anybody else? A. Nice. Keeping the patient NPO, maintain safe airway, and use aspiration precautions. All right, nice. All right, so you want to protect your airway until your mental status is improved. All right. And what labs are going to be abnormal? What labs are you expecting to be abnormal for this patient? Your liver function. Yes. Your liver function. So you have to keep an eye on the your liver function for this patient. All right. A patient on lactulose has 5 loose stools per day and improved mental status. What is appropriate? A. Continue lactulose and monitor electrolytes. B. Stop lactulose immediately due to diarrhea. C. Switch to antibiotics only. D. Reduce nursing observation frequently. So you have a patient on lactulose that has 5 stools per day and improved mental status. What is the appropriate thing to do for this patient? A. Continue lactulose and monitor electrolytes. B. Stop lactulose immediately due to diarrhea. C. Switch to antibiotics only. D. Reduce nursing observation frequency. A. Okay, continue lactulose and monitor electrolytes. Okay. Do we have anybody else? Carousel says A. All right. But the patient is having 5 loose stools. Why you want to continue it? Why you want to continue with the A put like B? Okay, but the patient, so B, stop lactulose immediately due to diarrhea. Okay, what is diarrhea? Repeat options. So A, continue lactulose and monitor electrolytes. B, stop lactulose immediately due to diarrhea. C, switch to antibiotics only. Or D, reduce nursing observation frequency. So a patient on lactulose, patient is stable, okay. So a patient is on lactulose, has 5 loose stools per day and improved mental status. What is appropriate? Continue lactulose and monitor electrolytes. Stop lactulose immediately due to diarrhea. Or switch to antibiotics only. Reduce nursing observation frequency. So which one would you choose? Life shines. You see how people can mix it up and I'm going to change the answers. So all the persons who had says A. All right, so A, continue lactulose and monitor electrolytes. So what is diarrhea expected with lactulose? Is that like one of the expected result? Are you expecting to have, really said D? So yes, it is expected, all right? It is expected, so stick to the answer. All right, so continue the lactulose. So continue the lactulose and monitor electrolytes, all right? So because the patient is passing all of that ammonia out, you understand, the patient is having improvement in their mental status, all right? If they weren't having improvement in it, then, then you'd be like, okay, then this is probably not working. I probably need to try something else. But the patient is having improvement in the mental status. So meaning the ammonia levels are, getting lowered. And that is what you want. That is the effects with the lactulose. It's supposed to cause diarrhea, let you pass out that stool, pass out that ammonia, and then improve your mental status. All right, so you'll continue with it and continue monitor your electrolytes. All right, what are some of the electrolytes that you'll be concerned about if this patient is constantly having diarrhea? What are you concerned about? Say a patient that is having diarrhea, a lot of diarrhea. What are you concerned about? Dehydration, sodium. Okay, so your potassium, all right, so your hypokalemia. So what acid-base imbalance will this patient be having? Well, this patient be having metabolic acidosis, metabolic alkalosis, respiratory alkalosis, respiratory acidosis. What would you be thinking about or expecting to find with this patient? The patient is having metabolic alkalosis. You reach, Island girl. You're late. Okay. So I was just saying regarding the patient here, this patient is having diarrhea. So you'll be monitoring the labs. So metabolic alkalosis, yes. So you'll be monitoring the labs. You know, you'll be expecting that this patient's, you know, lab values, electrolytes will be affected because if they're having the frequent diarrhea because of the lactulose, they're losing potassium, sodium, you know, chloride, all of those things they're losing. So you want to keep an eye on their electrolytes. But while you're keeping an eye on their electrolytes, if it is abnormal, or not even say abnormal, but this patient is going to be at risk for what acid-base imbalance when it is abnormal. Most of the time it's like metabolic alkalosis. All right, so that was just where we were at with that. All right. Metabolic alkalosis, yes. All right, so let's see. Switch to antibiotics only. Will you be giving this patient antibiotics? So the patient is on the lactulose, has 5 stools per day, and will you be giving this patient antibiotics? Will you be thinking about, okay, why you want to give them carousel? Or Melva? Why you wouldn't want to give this patient any antibiotics? Because we're not thinking that this, you know, this diarrhea is caused by any, okay, diarrhea. Someone causes diarrhea. Okay, because some antibiotics cause there. Yeah, we're not really thinking that this diarrhea is related to any, like, you know, bacterial, viral, nothing like that. Bacterial infection. This is something that is induced by the lactulose. All right, so we don't need to be thinking about antibiotics for this patient with the frequent diarrhea that they're having. All right. And reduce nursing observation frequency. You just continue with your monitoring, you know. But the most important thing is the patient is having improvement in their mental status. So depending on how far, you know, how confused they are, then you can always go ahead and adjust your frequency. But you want it to be a case where the patient is now awake and able to tell you 1 and 2 things correctly, you know. And then from there, you can always say, okay, I'll check on the patient every 1 hour, every 2 hours. But you'll adjust your frequency based off of your assessment. All right. A patient with peptic ulcer disease is on misoprostol. What drug is misoprostol? What is it commonly used for? I know we're dealing with GI, but you know, which patients normally be on misoprostol? Thank you, Fran. Which patient is normally on misoprostol? So we're dealing with GI patients, but what other, you know, like give me a patient that normally would be on misoprostol. That a lot of times, you know, patients will be taking it. That class of patient will be taking it. Patient with ectopic pregnancy, yes. So your pregnant mothers, all right, or pregnant persons will be on misoprostol, all right. So a patient with peptic ulcer disease is on misoprostol. What teaching is essential for women of childbearing age? All right. A, use reliable contraception. Misoprostol is abortifacient. B, it prevents diarrhea in pregnancy. C, no special precautions needed. D, it increases fertility. So you have a patient that is that has peptic ulcer, and they'll be using the misoprostol to help with that peptic ulcer. What teaching is essential for women of childbearing age? A, use reliable reliable contraception. Misoprostol is abort-efficient. B, it prevents diarrhea in pregnancy. C, no special precautions needed. D, it increases fertility. All right, so A, nice. Yes, so use reliable contraception. Misoprostol can cause uterine contractions and cause, fetal harm. All right, so a lot of times they use it whenever you're trying to induce your pregnant mothers. So definitely you want to make sure they're using reliable contraception when they are using that for their peptic ulcer. All right, it prevents diarrhea in pregnancy. I don't know about that one. No special precautions needed. You definitely do. And it increases fertility. Not at all. All right. A client with metronidazole. What's metronidazole, or what's the other name for metronidazole? 1 minute. What's the other name for metronidazole? Flagyl, nice. So a client on metronidazole, Zosyn. Oh no, not Zosyn, Melissa, Flagyl. All right. So a client on metronidazole or Flagyl asks whether they can drink alcohol. What is going to be your best response? A, avoid alcohol during therapy and 48 hours after to prevent disulfiram-like reaction. B, small amounts are fine. C, alcohol increases efficacy. Or D, only avoid beer. So a client on metronidazole asks whether they can drink alcohol. What is your best response? Tell them no. Yes. Avoid alcohol during therapy and 48 hours after to prevent disulfiram-like reaction. All right. Small amounts are fine. No. Alcohol increases efficacy. Definitely not. Only avoid beer. No. All of those are incorrect. All right. Let me look up this one. Let me look up. All right, so a disulfiram-like reaction is an adverse reaction that occurs when alcohol is consumed while taking certain medications. All right, it is caused by the accumulation of acetaldehyde, a toxic byproduct of alcohol metabolism. So some of the symptoms are flushing of the face, neck, chest, nausea, vomiting, headache, rapid heartbeat, low blood pressure, sweating, dizziness, confusion, seizures in severe cases. All right, and metronidazole, antabuse, ginkgo, tolbutamide. Those are some of the medications that can cause disulfiram-like reactions. Okay. All right, learn that one. All right, a patient receiving octreotide for varicose bleeding shows hyperglycemia. So a patient receiving octreotide for varicose bleeding shows hyperglycemia. Why? I remember octreotide from nursing school. I haven't really seen that in a long time. What's octreotide? I think it was on a gynae. I don't remember where. So, okay. I haven't seen this drug in a long time. Okay. Octreotide. So it is used to treat severe diarrhea and other symptoms that occur with certain intestinal tumors. All right. Or metastatic carcinoid tumors. All right. So a patient receiving octreotide for variceal bleeding shows hyperglycemia. Why? A. Octreotide can inhibit insulin release, leading to hyperglycemia. B. Octreotide increases insulin sensitivity. C. It causes immediate hypoglycemia only. D. No effect on glucose. So a patient receiving octreotide for variceal bleeding shows hyperglycemia. Why is that? A. Octreotide can inhibit insulin release, leading to hyperglycemia. B. Octreotide increases insulin sensitivity. C. It causes immediate hypoglycemia only. Or D. No effect on glucose. So A, okay, nice. Yes, so that's the answer. Octreotide can inhibit insulin release, leading to hyperglycemia. All right. So it inhibits insulin release, leading to hyperglycemia. So as we say, anything that has the word, the word only as, a part of the answer, eliminate that one. It causes immediate hypoglycemia only. So eliminate that one. No effect on glucose, but it can inhibit insulin release. So that's the answer. So somatostatin analogs can alter glucose metabolism. So the most important thing is octreotide can inhibit insulin release, leading to hyperglycemia. All right. Which medication is contraindicated in acute pancreatitis for pain control? Meropenem or Demerol, which is used with caution due to metabolite risk. B. Morphine, acceptable per order. C. Hydromorphone, which is acceptable. D. NSAIDs per order. So which medication is contraindicated in acute pancreatitis for pain control? A. Meropenem or Demerol, used with caution due to metabolite risk. B. Morphine, acceptable per order. C. Hydromorphone, acceptable. D. NSAIDs per order. So A, D, and Alfie laughing after her D. Meropenem, not meropenem. Meropenem. So pain medication. So which medication is contraindicated in acute pancreatitis for pain control? So the answer is A, the meropenem. Why did you say A, Fran? You're a good one, Brady. Why did you say A, Fran? Why did you say meropenem, Demerol? Use with caution due to metabolite risk. So the answer is the meropenem, Demerol. That one is contraindicated in pancreatitis for pain control. And it says here, meropenem can accumulate. All right, opioid choice should be very cautious. So I guess because of the metabolite risk. So I don't know much about that one. So that's the answer, this says. All right, so if you have meropenem, morphine, hydromorphone, and NSAIDs, then, choose the hydromorphone or the morphine and leave out the meropenem or the Demerol. All right, when you have your pancreatitis patient. All right. A patient with H. pylori infection requires triple therapy. Which combination is typical? All right. Is it A, the PPI plus clarithromycin plus amoxicillin or metronidazole? B, PPI only. C, antibiotics only without acid suppression. D, long-term steroids plus antibiotics. So a patient with H. pylori infection and that patient requires triple therapy. What medication are you anticipating? Is it A, PPI plus clarithromycin plus amoxicillin or metronidazole? B, PPI only. C, antibiotics only without acid suppression, or D, long-term steroids plus antibiotics. Nice. Yes. So PPI plus clarithromycin plus amoxicillin or metronidazole. All right. So standard triple therapy includes acid suppression plus 2 antibiotics. And usually the regimes, they vary. All right. So you just have to make sure you look at which one of the regime you're going to be using. All right. But you always want to go ahead and get your acid suppression and then your antibiotics. Oh, yeah. Oh, Lord. Oh, my word. Althea is asking where was I when she was doing her exam. When did you do your exam? All right. So you always want your PPI plus your 2 antibiotics. All right. So clarithromycin, amoxicillin, the PPI, and we said the PPI can be any one of your zoles. All right. Pantoprazole, lansoprazole, omeprazole, anything like that. All right. Antibiotics only without acid suppression. That's wrong. Long-term steroids plus antibiotics. No. All right. A nurse giving IV pantoprazole push must A, follow facility protocol for rate and dilution. Rapid push may cause arrhythmia. B, always give as a rapid bolus. C, rotate site per administration. D, mix with calcium chloride. So you have a nurse giving IV pantoprazole push. What must the nurse do? A, follow the facility protocol for rate and dilution. Rapid push may cause arrhythmias, all right? B, always give a rapid bolus. C, rotate site after administration. Or D, mix with calcium chloride. So yes. Always follow your facility protocol for rate and dilution. All right. Always give us a rapid bolus. You always do like a slow. You know, you can do the bolus, but you do it slow. It doesn't have to be rapid. You don't normally do the rapid push on it. You know, a lot of times we tend to be like in a rush to, yeah, but you're supposed to be slow over a certain time period. Rotate site after administration. So this is IV. So a lot of times, you know, most of the time the patient might just have 1 or 2 IVs. Nothing is wrong with switching in between, but it's not like you're going in the muscle, you know, you're doing IM injection where you're thinking about, you know, fat breakdown or anything like that. We're not doing that. So it's okay to, you know, if they have 1 IV working with, you give it. Just make sure you're flushing in between. All right. But if they have more than 1 IV, nothing is wrong with rotating. But rotating site after administration sounds more like they're thinking about, you know, the IM, the injection. All right, so we don't have to be concerned about that one. Mixed with calcium chloride. Nah. Not gonna mix anything with no calcium chloride. All right, but follow facility protocol for rate and dilution. Rapid push may cause arrhythmia, so you always go ahead and do your slow push. All right. So you do your slow push based on whatever the orders are, and then you'll hang your maintenance bag depending on what the orders are. All right. And if you know, sometimes you can always just talk with the doctor to find out if they need the bolus, you know, if they need to do the bolus before they start the infusion. All right. A patient on lactulose develops hypokalemia. Which is nursing priority? A, monitor electrolytes and report low potassium to provider for replacement. B, stop the lactulose immediately. C, increase dosage of lactulose. Or D, decrease oral intake of lactulose. So you have a patient on lactulose develops hypokalemia, which is the potassium, low potassium. Which nursing priority? Which is nursing priority? A, monitor electrolytes and report low potassium to provider for replacement. B, stop lactulose immediately. C, increase dosage of lactulose. Or D, decrease oral intake of potassium. So we have A, monitor electrolytes and report low potassium to provider for replacement. Yes. All right. Pretty says stop lactulose. Okay. So all of these are So B. So stop lactulose. All right. So the patient develops hypokalemia, which is nursing priority. Monitor electrolytes and report low potassium to provider for replacement or stop lactulose immediately. All right. So you have this patient here on, you're going to stop the lactulose immediately, or you're going to monitor the electrolytes and report the low and get it replaced. So diarrhea causes hypo. All right, so the lactulose is obviously doing what it's supposed to be doing. So this patient is going to be having the diarrhea, which is one of the main reasons for the patient to be on the lactulose. All right, you stop then report. All right, yeah. Well, then again, with the lactulose, remember most of the time they drank, they're drinking the lactulose. All right, so they would have already ingested that one. So I guess 6 hours, however, whatever time period they're supposed to be getting the next one, you'd probably just go ahead and hold off on it. But in the meantime, during that time, you would go ahead and still advocate. Call the doctor, let the doctor know that, the potassium comes back as being low, and then they will replace it. But even though the order is there for a replacement, it doesn't mean that the doctor has to stop the lactulose because you're replacing it. The patient needs the lactulose. All right, because that is what is going to help with getting that ammonia out. So even though the lactulose is there, that is not like, stopping it is not priority, because probably the patient is not due the next dose until 6 hours time, 8 hours time. You understand? So even though, yes, you're probably thinking that, oh, let's stop the thing, you just go ahead and monitor the patient in the meantime. So if you're replacing the potassium, you can still go ahead and give your lactulose, because your patient definitely need the lactulose. All right. Okay, I didn't know why on lactulose. Most of the time, sometimes it depends. Most of the time, some people give lactulose for diarrhea. Some people, yeah, I like lactulose for diarrhea sometimes, but it's not something that you give them like a lot, but we give it sometimes for diarrhea. Because, you try other medication, and when you give them one dose of lactulose, like, whew, all of that impaction gone. You understand? So we tend to do it sometimes, but it's not like the first choice. All right, but a lot of times when you have your patients on lactulose, a lot of them are having their liver problems. And so, they always give it just because they don't want that ammonia level to start increasing. And then from there, yes, you give a little bit for constipation. Because you have some patients who are like severely impacted, and nothing that you try does help. And then from there, you give them a little lactulose, it does help with that as well. So, are you speaking from the US? Sorry. I am currently in the US. I like how you. Thank you, Fran. Do I teach? No, I don't. I love teaching though, but I don't teach like, yeah. I was precepting some students here, but yeah, not my cup of tea for the US. No disrespect. Yeah. In the clinical side, I guess, my training is a little bit different. And so the expectation here is a little bit different. So it's just not, adjusting to certain things. But yeah, I love teaching though, but I don't really teach like, anything like that. All right, but as we were saying regarding the lactulose, just think of it that the patient is going to be on scheduled lactulose orders. So in the meantime, what you're going to be doing is you'll continue monitoring. You report it to the provider, and then they will go ahead and replace. But as I said, the patient is, the lactulose is very important for that patient. So you definitely want to go ahead and continue with it. All right, because you're replacing it. So even though you probably see where it's at 2.9, it's low 2.5, you're doing your potassium replacement, and then you'll be doing your frequent checks. So depending on how often you want to go ahead, if it was critically low, then, but you'll continue with your lactulose. All right. So if this patient has hypokalemia, his patient's potassium is like 2, what are some things that you definitely want to be doing for this patient? So you're giving this patient, the lactulose. The patient is low in terms of potassium. What are some things you're anticipating, or what are you going to be doing for this patient now that the patient potassium is at 2? What are you going to be doing as a part of your nursing duty? So you go ahead and phone the doctor and tell the doctor, hey doc, potassium is 2. Okay, so what am I supposed to do? Or, you call the doctor didn't answer. What are you going to be doing in the meantime with this patient potassium being so low? All right, let me start off. So we have one IV in place. So what are some other things that you definitely want to be doing for this patient in terms of your nursing care? The doctor may order ECG, but what if you call the doctor? You call the doctor 2 times, 3 times, and you're still waiting. What can you be doing for this patient? So the doctor may order ECG. You call the doctor, 20 minutes, the doctor hasn't, but the patient is still there, What are you going to be doing? Are you going to do the EKG? We can't do anything without an order. No, you can't do anything without an order. You definitely need an order, but the doctor is going to need an EKG. So definitely go ahead and get your EKG. It's not going to hurt. It's either the doctor take it or leave it. You understand? But you're going to do your part because you know that the patient is at risk for arrhythmias. All right. So you definitely want to go ahead and get your EKG. All right. So go ahead and get your EKG. The doctor is definitely going to sign off on it. All right. If the doctor don't sign off on it, that doctor is very petty. You understand? But just make sure you document that you do your EKG because you know that this patient is at risk for arrhythmias. So the doctor is definitely going to need it. You need a baseline EKG. You're also going to put your patient on the monitor. We can't do EKG without an order. Yeah, you can't do an EKG without an order. You can put in some patients have proper EKG. You don't have like standing orders. You don't have standing orders. You can put it as a verbal order. If it's a case where you definitely need it transmitted to the EKG machine. But what about those patients so if you have a patient that is, patient comes in and the patient is coding, in case of an emergency, you should be, yes, Fran, that's what I was going to say. So in the event that you have a patient coming in and that patient is, the patient is coming in and you got the report from the ambulance. They already did their, first EKG and that patient is in Vita. They've done a few things and get John Doe or Jane Doe through the emergency door, depending on where you're working. You get that patient. Nobody knows the patient's name or anything. You don't have time to go and register, put order in and all. You have time now to jump on and put on EKG leads and get an EKG. So there is some way for you to actually do an EKG. So not all the time you're going to have to input the patient's name, date of birth, sex, and all of those things. That can come afterwards. You understand? But you need to get those electrodes on, or electrodes on. Why am I saying electrolytes? You need to get that electrodes on so you can see what rhythm the patient is in. So if it's an emergency, you definitely need it. So your patient who is hypokalemic, not kalemic, the patient who has hypokalemia that has a low potassium is an emergency. All right. So if you call the doctor and the doctor is not there, you have to get an EKG in that time period. Get the EKG in the meantime. You can always input certain things in the system to get the EKG going for that patient. So even if you don't have the doctor's order, you can either put in, there should be some way for you to bypass the system to get that EKG. There's always a way for you to bypass the system. It might not transmit to the patient's chart, but you're able to still print out a rhythm strip. So you need to find out how to go ahead and enter emergency EKG on your EKG machine. But in the meantime, you'll get your EKG. You will also connect your patient to the cardiac monitor, as they can do without an order. Even on the floor, you can. Even on the floor, because when I used to resource the different floors, I'm still able to bypass. You just have to know how to bypass that section. But there's a way for you to enter, because if you have a patient, you can't. Okay. Because if you have a patient that is, if you have a patient in the hallway, you're passing and you have a patient that codes, and the closest bed to you is wherever, and you have an EKG machine and you don't have a doctor to put that order in, you're not going to get an EKG on the floor. It depends on where you work. Yeah, you're not going to be able to get that EKG on the floor. You have to wait until that patient is registered and then get the EKG order and then transmit it over to the patient's chart. And then you do the EKG. That's like a lot of time. But most of the EKG machines have worked with that different facility. There are ways for you to actually do it. So you can ask them how they go about with entering that information. So is either you're going to put it as a verbal order, and most of the time when you put it as a verbal order, when they see that a patient is coding, or depending on what is going on, like nobody is going to be like, oh no, you should have waited for an official order from the doctor. Like, no, you understand, you're thinking about a life. So just find out how to do verbal orders and put it in. And then from there, we were told not to. For EKGs? Okay, all right, no problem. If you were told so, that's fine. All right. If you were told so, then that's fine. All right. But most of the time, when it comes down to like your emergency, you can go ahead and do your verbal order. So you have to know what is emergent. You have to know what is an emergent, EKG versus a non-emergent EKG. All right. You have your EKGs that need to be done in certain time period. Your 10 minutes time period. So if you phone a doctor and the patient is having chest pain and you don't have an order, most of the time you might not have an order if it's a new patient or if it's a new onset chest pain. You will find out that that's strange. So if you have that time, you have that 10 minutes time period, 10 minutes time, the window for you to get that EKG in. All right. So you always go ahead and get your orders in. If it's a verbal order, you get it in and you get your EKG. Whenever the doctor puts the official order in, you can always go back and reprint it until, with their information in the system. But you want to capture that EKG within that time period to meet your facilities, your facilities goal with their chest pain protocol. All right. Me not sign your verbal order. Okay. I've worked at multiple hospitals and never had any issues with that. But if you say so, depending on where you're working, but you must, just identify, know what your verbal orders are, and then from there. You understand? I've never done an EKG, even if it's not a dire emergency. I've never done an EKG, and I do an EKG on sepsis patient all the time. And I've never had any issues with a doctor signing off. And 3/4 of the time, no orders are in. Because by the time the doctor puts those orders in, everything done for the patient. You understand? So it depends on where you're working and the providers that you're working with. But a lot of times they have those 10 minutes time period that they're working with. And they love you whenever you're very proactive. You get those EKGs done in a timely manner. All right, so... All right, so for that patient, you definitely go ahead and try to get your 2 large bore IVs. All right, always try to get some large bore IVs for your patient. You're going to go ahead and get your patient connected to your cardiac monitor. You get your EKG. Not all emergency rooms have standing orders. Some facilities I work at do have standing orders, some don't. But when they come into the emergency room and you're working in triage, so for example, you're working in triage and the patient comes in, you might not even complete the triage, but you're getting your EKG. So there's no doctor there all the time to put an order in, but you have your EKG. So you'll get your EKG, your 2 large bore IVs, and you phone your doctor. Put the patient on a cardiac monitor. Make sure the patient is in a gown so you can always have the chest exposed, things like that. All right. Stop lactulose immediately. As I say, it depends. It depends. You want to really say stop the lactulose like that because more than likely the patient would have already gotten their dose and probably anticipating their next dose. So it depends on where you are. All right. In terms of that, increase dosage of lactulose. No, you don't increase the dosage on the lactulose. All right, you'll keep your lactulose dosage. The doctor will adjust as needed. But if you increase it, you're gonna worsen their hypokalemia. All right. So you don't want to increase the dosage on that. Depending on, when you repeat your electrolytes and see what the potassium is, then from there they will adjust it. Decrease oral intake of potassium. For this patient, the patient is hypokalemia, decreased oral intake. No, if the patient is good with eating, then definitely. So as long as the patient is able to swallow, the mental status is good. Patient is not confused, and there is an order for the patient to eat, then you can always give your high potassium foods. All right, so your potatoes, your bananas, all of those things, you can always go ahead and give the patient as long as that is okay. But decrease oral intake, no. The patient is already hypokalemic, so you don't want to decrease their potassium intake. You don't want to increase it. All right. So monitor report for replacement. Diarrhea can cause potassium loss. Replacement as ordered is important. All right. So a client with active varicose bleed receives vasopressin. What is important to monitor for this patient? A, signs of ischemia in extremities and coronary ischemia. B, only mental status. C, blood glucose only. D, hair growth rate. So you have a client with active varicose bleed receiving vasopressin. What is important to monitor for this patient? A, signs of ischemia in extremities and coronary ischemia. B, only mental status. C, blood glucose only. Or D, hair growth. So Melva says A, signs of ischemia and extremities and coronary ischemia. What is vasopressin gonna do? In terms, is vasopressin a constrictor or a vasodilator? Practice is vasodilator. So is vasopressin a vasodilator or a vasoconstrictor? So vasodilator, I think it's a dilator. No, it's a vasoconstrictor. All right, so that's why you're gonna be looking out for any signs of ischemia. All right, so a client with active varicose bleed receiving vasopressin, so you're trying to squeeze, help with decreasing that bleeding. All right, so it's a vasoconstrictor, so you're trying to help with slowing down that bleeding there. So you want to definitely be monitoring for any signs of ischemia in the extremities as well as the coronary ischemia. So you want to be looking at your EKG, look for any EKG changes there. Make sure you're looking at your blood pressure as well. All right. So what are some, so for example, you have this patient in terms of the ischemia, signs of ischemia. What are you looking at in terms of with the extremities? What are certain signs or symptoms of ischemia in the extremities? What are you looking for? So you have this patient in bed. The patient is on vasopressin. The patient is covered numbness. Okay. The patient has a socks on. The patient has a pants on and, well lying down in bed, covered up. You're giving this patient vasopressin. What would you be concerned about with that patient? Numbness, tingling, pulse rate. Okay. All right. Anything else? Cold. Yes. Okay. So definitely you want to take off those socks. You understand? Take off the socks and make sure you're keeping an eye on the toes to make sure it's not changing color. Paresthesia, blue, cyanotic. You understand? Make sure, you're not seeing any of those, because the ischemia is going to start from the toes and then take its little time and work its way up to the heart. All right. So the smaller extremities, the fingers, look at those to make sure they're not cold, they're not cool, they're not cyanotic. Because what happens is that, the body is going to go into this compensatory mode where it starts, it's going to shut down from the lesser organs. and then, you know, it work its way up to your major organs. So your fingers, your toes are going to start getting blued, cold, you know, you're going to feel numb, things like that. So make sure you're observing your patients properly when they're on vasopressin. All right. Only mental status changes. No, you're not going to only, and as I say, anytime you see any answer that says only, just eliminate that, because there's so many other things you can be monitoring for. So only mental status is definitely out. Blood glucose only is definitely out. And hair growth rate, really, I don't know about that one day. You understand? That one is just like, yeah. But definitely with the ischemia, with the vasopressin, you want to monitor for ischemia. All right. Vasopressin causes vasoconstriction and risk for ischemia. Which drug is used to slow GI motility in acute diarrhea? What medication causes, you know, your GI to slow down when you have patients with diarrhea? Is it A, loperamide, B, metoclopramide, C, misoprostol, or D, octreotide? So loperamide with caution if infectious cause. B, metoclopramide to slow motility. C, misoprostol to slow motility. Or D, octreotide to always speed motility. Melva, what time class finishing? Oh, you want to sleep? Let me look how far. Let me look how far. So, oh, Lord. I guess because we're chatting so much. What time is it? 10 o'clock? Okay, I thought it was later than this. Okay. I'm gonna, so I had 100 questions in mind. It is so interesting I can leave. Okay. I had 100 questions in mind. I think probably what I'm going to do, I'm going to start to cut it down to 50, because it's not necessarily just focusing on the questions A, B, C, D. Try to look at the rationale and try to answer other things, you know, from that same one question. I think it kind of broadens our knowledge. You can sleep and check it out on YouTube tomorrow. Oh, yes, Woon really says it correctly. All right, it will be placed on, it's uploaded to YouTube, so you can always go onto YouTube and check it out. But Woon really, she won't be able to have this interaction, because I posted one today, and there was one person who was DMing me on TikTok here saying, I'm trying to talk to you and I'm not getting through. I have to rewatch tomorrow. It will get in my line of duty. Okay, no problem, Melva. Thank you so much, though, for tuning in. All right, thank you so much. But whenever you guys are ready, then we can go. I don't have work tomorrow, but I have to finish up my hair. I'm gonna finish up after. But yeah. So I had 100 questions that I wanted to do. I think probably this would be pushing it. So I'll probably just do. You want me to do 10 more questions? How much is that one? Okay, so I can finish up this section here. Okay, I can finish up this section. Where was I? 45 to 50, so that's 5. So I have 20. I can do 20 more questions if you guys want. I can do 20 more questions or 5 more questions. All right. But as I say, I normally say 7 to 8. But then depending on the interaction, then I am free. So I'll go until I finish the questions. Please, where can we access some of the question banks if needed? Nursing with Paul. So these questions are not from a nursing bank, all right? These questions are not from a nursing bank, because what I'm trying to do is more of a study So there are study questions that I got from the internet. All right. There are study questions that I got from the internet. And as we go along, I might be talking about a cirrhosis patient. I might be asking you other questions that are not on this. So it's not necessarily from, I don't have a specific bank. It's like a few questions that I put together and I just have them. And then I'm just asking additional questions as we go along based on the question that we're at. So I don't really have, you can go on to Quizlet. You can also do UWorld. All right. I don't have a UWorld subscription, but I draw questions from different, different places and then from there. All right. But as I say, like some of the questions that I might be asking, so for example, I have a question here regarding a tuberculosis patient on medication. Like I might ask 4 additional questions that has nothing to do with it. We might just be going down a rabbit hole with the one question, just to kind of broaden our knowledge. That's all. All right. So I don't really have it coming from one specific area. All right. So we had said that. So which drug is used to slow GI motility in acute diarrhea? A, loperamide with caution in infectious cause. B, metoclopramide to slow motility. C, misoprostol to slow motility. Or D, octreotide to always speed motility. So you have a patient that has diarrhea. Which medication will you use? Loperamide. Definitely. I think I'd asked it already. So loperamide, if caution, you use it with caution if it is an infectious case. All right. So loperamide decreases motility, avoid certain infections or toxic megacolon. Metoclopramide, what medication is that, or why do you use that medication? What are we treating with it? If you have a patient with metoclopramide, on metoclopramide, what are you treating? What is it used for? Metoclopramide. It's an antiemetic, yes. All right. Emesis, yeah. All right. So misoprostol, we already talked about that one. Nausea and vomiting, yeah. So misoprostol is the one that we use in pregnancy, and we say that you definitely need to make sure you're educating your patient about using alternate, barriers in terms of contraception. And octreotide is the one that we say is used in like some form of tumors. All right. So definitely with that one as well. All right. A patient receives. All right, we did one of that already. So a nurse receives antiemetic Zofran. A nurse gives antiemetic Zofran. Which side effect is she supposed to be monitoring? A, prolonged QT interval on ECG. B, tachycardia always. C, increased appetite only. Or D, hyperreflexia only. So a nurse gives antiemetic Zofran for something for nausea. Which side effects is she monitoring? A, prolonged QT interval on ECG. B, tachycardia always. C, increased appetite only. D, hyperreflexia only. So which one is she monitoring? So K says D. Oh, cry J Pinnock. D. Smiley says D. Hyperreflexia only. Anybody else? Okay. So remember, say anything that has only hyperreflexia only. No, that's not the only thing you're going to be monitoring. All right, so that one is out. Increased appetite only. That one is out. All right, so the prolonged QT interval on ECG is something that you have to be concerned about, as well as the metoclopramide. So both of them, most of those drugs tend to cause prolongation with the QT interval, all right? So always go ahead and monitor your patient with that. So get them, I know a lot of times we probably don't have them on the monitor or we don't get an EKG, but if they're gonna be on it long term, you know, high doses of it, you wanna keep an eye on, you know, your QT interval. And it's the same thing for your Reglan as well, all right? Tachycardia always, no, that's not all the, you know, not all the time they're having tachycardia, so you don't have to be monitoring for tachycardia always, all right? But a prolonged QT interval is something that you'll be concerned about with a lot of your nausea medication. So your Zofran, your Reglan, all right, and then from there, Zofran can prolong QT. Caution with other QT prolonging medications, all right? And you know that alcoholism, persons who drink tend to also have prolongation with their QT interval, all right? So that is another thing that you have to be looking at, all right? An elderly patient has fecal occult blood, positive, and anemia. Which should the nurse prioritize? So you have an elderly patient who has fecal occult blood, and it is positive, and they are also anemic. Which should the nurse prioritize? A, notify the provider for colonoscopic evaluation and stabilize hemodynamically if needed. B, ignore and assume it's an hemorrhoid. C, start iron without further workup. Or D, give stool softener only. So you have an elderly patient who has fecal occult, blood positive, and they're anemic. Which should the nurse prioritize? A, notify the provider for colonoscopic evaluation and stabilize hemodynamically if needed. B, ignore and assume it is a hemorrhoid. C, start iron without further workup. Or D, give stool softener only. All right, so we have A, notify provider for colonoscopic evaluation and stabilize immediately, hemodynamically if needed. All right, why are you concerned about this though? What part of it is concerning for you? Is it just the fact that the patient has a fecal occult blood that is positive, or the fact that the patient is anemic with it? Because if the patient is the blood loss, definitely. All right, because more than likely it's not no small bleed or anything that is causing that. Hemoglobin can drop. Yes, it has already dropped. So, you know, it's not a matter of, it's a matter of why is this patient bleeding so heavily, why the patient is anemic. All right, so we definitely need to explore that. All right. Ignore, assume it's hemorrhoids. No. Sometimes, you know, you can examine the patient, and then if it was just the fecal occult blood loss and it was positive, or the fecal occult positive, blood positive, and you look and you examine and you see that there is a hemorrhoid, but when you look at the labs, the hemoglobin is normal, then you can assume that probably it is because of the hemorrhoids. But if you see like the significant change in the hemoglobin, then you have to assume that bleed is because of something bigger than, you know, the little hemorrhoids that you see there poking around. Start iron without further workup. That's a no. You understand? You want to make sure you still go ahead and do your additional workup and look at the different levels for this patient in terms of their iron. Give stool softener only. No, there are other things you're going to be needing to give to this patient, all right, apart from the stool softener. So notify the provider so they can get this patient prepped for colonoscopy, and then at least they'll be able to identify the source for this bleeding and then address the anemia in the meantime as well, all right. A patient with Crohn's disease presents with fever, severe abdominal pain, and leukocytosis. Can't give iron without an order. Definitely, you cannot. All right. You have a patient with Crohn's disease. A patient with Crohn's disease presents with fever, severe abdominal pain, and leukocytosis. Which complication is most likely? So you have a patient with Crohn's disease presenting with fever, severe abdominal pain, and leukocytosis. Which complication is most likely? A, abscess or perforation. B, simple viral illness. C, migraine. D, tension headache. So you have a patient that has Crohn's disease and presents with fever, severe abdominal pain, and leukocytosis. Which complication is most likely happening there? Is it A, the abscess or perforation? B, simple viral illness. C, migraine. D, tension headache. Okay, nice. A. All right, so abscess or perforation. All right. Is it something that, you can prep this patient for, surgery, or depending on what is going on? Is it something that needs urgent evaluation or can wait? Is this a patient that can wait, or you definitely need this patient to be evaluated? So this is an urgent situation. Yes, it's very urgent. So you definitely go ahead and address that. All right. The mere fact that patient has leukocytosis, it's important. All right. The fever, the severe abdominal pain. All right. Simple viral illness, that's a no-no. All right. Especially because the patient is having the severe abdominal pain and the leukocytosis. You want to think something that is bigger. For migraine, what are some of the signs and symptoms of migraine, that you'll be expecting for a patient? What are some of the things that you'll be expecting for a patient to who has migraine? The aura, okay. The lightheadedness, okay. Light sensitivity, yeah. Alright, so photosensitivity, nausea, sometimes they probably have a little, vomiting, depending on the severity of it. Nice, yes. Alright. Tension headache. How would you know a patient is having a tension headache? What are some things that they might say to describe their headache? Pretty. I don't understand that. Pretty. The last one. Heavy head. Okay. What are some of the things that they would say? A lot of times they tell you that they have like a squeeze in one section of the head. Okay, yes. A tightness, like a band is tightened around their head, squeezing. All right, so that's what, a lot of times they will be telling you, along with all the other things that you said. All right. All right, so the best answer: patient with Crohn's disease presents with fever, severe abdominal pain, and leukocytosis. The complication that is most likely is the abscess or perforation. All right, so Crohn's disease may perforate or abscess, and it might require or will require surgery and antibiotics. All right, a patient on high dose of corticosteroids and for autoimmune hepatitis must be monitored for A, GI bleeding, B, hypoglycemia only, C, always decreased appetite, or D, skin dryness. So you have a patient that is on high dose of corticosteroids for autoimmune hepatitis. What are you going to be monitoring this patient for? A, GI bleeding risk, B, hypoglycemia, C, always having decreased appetite, or D, a dry skin. So B. So GI bleeding risk and assessing for infection. So B is hypoglycemia, C is always decreased appetite, or D, skin dryness. So a patient on high dose of corticosteroids for autoimmune hepatitis must be monitored for A, GI bleed risk and assess for infection, B, hypoglycemia only, C, always decreased appetite, and D, skin dryness only. So D, D, B, okay. So the one that is A, so A is going to be the correct answer. The GI bleeding risk and assessing for infection. All right, remember this patient is on high dose of corticosteroids, so they're at high risk for infection. All right. And then the hepatitis, that patient is also going to be at risk. Hyperglycemia. Hypoglycemia was one of the options. All right. So hepatitis. So autoimmune hepatitis must be monitored for. They have GI bleeding risk as well. All right. Because you have this patient on high dose corticosteroids. All right. So you monitor for GI bleeding risk and assess for infection. All right. So assess for infection because of the patient being on a high dose of corticosteroid. And with hepatitis or with the liver having problems going on there, the patient is also going to be at risk for for bleeding. All right. So definitely you want to go ahead and monitor that patient. So GI bleeding and infection risk. Steroids increase peptic ulcer risk and infection susceptibility as well. All right. A patient on isoniazid. So which patients are normally, or which condition you can think about that is that a patient that is taking isoniazid? So there's a condition that a lot of times you'll see that condition popping up, and they talk about isoniazid with some other medications for treatment. Do you know what other condition I'm thinking about that you use isoniazid for? It's a respiratory problem. TB, yes, tuberculosis. So a patient on isoniazid develops elevated LFTs and jaundice. So their LFTs, liver function tests, are elevated and they develop jaundice. What's the priority? All right. A, stop hepatotoxic drug and notify the provider and assess for drug-induced hepatitis. B, continue medications and watch. C, increase the dose of isoniazid. Or D, encourage alcohol to soothe. So a patient on isoniazid develops elevated LFTs and jaundice. What's priority here for this patient? A, stop hepatotoxic drug and notify the provider and assess for drug-induced hepatitis. B, continue medications and watch. C, increase the dose of the isoniazid. Or D, encourage alcohol to soothe. So if you have this patient and the patient has elevated LFTs, because you have this patient, the labs were normal, then now you realize that the patient's liver enzymes are elevated and the patient has jaundice, what's going to be your priority? Okay, Woonbreley says A. Okay, do we have anybody else? Any other answer? So if you have a patient that is on isoniazid and then the patient starts having elevation in their liver enzymes, their liver enzyme starts increasing, which means you have some damage going on there, what are you going to be doing? What is your priority for this patient? Is it to stop the medication because it's causing damage to their, their liver and notify the provider? Are you going to continue medications and watch a little bit more? Are you going to increase in the dose of the isoniazid or encourage alcohol to soothe, that patient's, I guess the liver and everything else? Relax the patient. So what are you going to be doing for this patient? What are you going to do? All right, so definitely you want to go ahead and stop that medication, stop the hepatotoxic drug, and notify the provider. Yes, so if you notice that the patient had, the patient was on the medication before and everything was not on the medication and everything was fine. The labs were normal. No, you did started this patient on a new medication and you did a repeat on the labs and you realized that, oh, the liver enzymes are elevated. More than likely it's because of something that the patient recently took. So you always want to try to find out, is there a new, something that you recently added in terms of your medication, and they might show you the newest of the medication. You might just say, okay, then hold off on this and let's get, a repeat on your labs to see what the numbers are. And then from there, if you notice that since they've started this medication, then their labs become abnormal, you're going to stop that medication completely, all right, because it's causing damage. So the isoniazid is causing this patient to have elevations in their LFTs, their liver function test, which means that that medication is hepatotoxic, all right? So you have to be careful with the liver. All right, so you notify your provider, and then from there, all right, continue meds and watch. You want to continue medications and watch. You'd stop the medication and watch. So if you realize you stop the medication and you realize that the numbers are improving, then you'll know definitely that, oh, it's that medication that is causing the problem. Increase the dose of the isoniazid. No, you don't want to increase the dose of the medication that is causing the problem. You stop it and then from there, all right? Encourage alcohol to soothe. Definitely you don't want that because this patient liver is already frying. You're going to introduce alcohol now to this patient is going to cause the same problem. So you want to avoid any alcohol with this patient, all right? And then from there. So hepatotoxic drugs require immediate evaluation. So definitely stop the medication and observe, as well as let your provider know. And then from there, they will go ahead and continue monitoring. All right. A patient with acute diverticulitis develops hypotension and rigid abdomen. The nurse suspects what? So you have a patient that is having, hypotension, and the patient is also having like a board-like or a rigid abdomen. What are you thinking? I'm not going to read the answers here. What are you thinking for this patient? Let's see. So you have a patient with a rigid abdomen or board-like abdomen, and the patient is having a lot of pain. The patient becomes hypotensive, probably having fever. What are you thinking? Peritonitis. Okay, nice. All right. Do we have anybody else with another answer? All right, so yes, the answer is the peritonitis. So the options are perforation with peritonitis, viral gastroenteritis, mild constipation, or anxiety attack. All right, is that peritonitis or perforation with peritonitis, is that like an emergency or not? Is this something you can say, okay, we'll book the patient for surgery in 2 days? Is that something that, you're anticipating, or you're thinking that this patient needs to go to surgery today, tonight? No. What are you thinking? Is it an emergency, a surgical emergency? Top priority, definitely, definitely. So you have this patient that is, having peritonitis, the board-like abdomen, rigid abdomen. Are you going to be feeding this patient, or what are some of your plans for this patient? What is going to be your top priority for this patient right about now? So the patient is going to go to the OR. What are some things you can do for the patient in the meantime? Nothing per month, definitely. So you keep the patient NPO. Okay, nice. What else can you do for this patient? Can get the paperwork for consents ready in the meantime. You can also make sure the patient have 2 working IVs, they're not eating or drinking, get the patient in their gown, things like that, to hasten the process to get the patient over. Can start them on their fluids for keeping that vein open until the provider comes, antibiotics, pain management, all of those things if it is order. All right, and you do your vital signs. All right, so you prep the patient in the meantime for the operating room, and then from there. All right. Viral gastroenteritis, no, mild constipation. Yeah. Preoperative management. Yes, definitely. So diverticulitis can perforate, causing peritonitis and sepsis. All right. So an hospitalized patient receiving enteral feeding develops sudden respiratory distress after bolus feed. What is the immediate nursing action? So you're feeding this patient, and you realize that after you feed the patient, you realize that the patient starts having respiratory distress. The patient starts to become low. The patient is just not breathing, breathing how they normally do. They're a little bit faster than usual. What are you going to be doing for this patient? All right, so the patient is receiving enteral feeding and the patient develops that. What are you going to be doing? You can tell me. So you're feeding this patient. This patient has enteral feeding going on, and this patient starts, becoming distressed. Patient is having respiratory. This patient is becoming distressed, and you realize that. What's this for? You realize this patient is becoming distressed, and you realize that what else? And it's after the feeding. What are you gonna be doing? Assess for risk for aspiration. Yes, always go ahead and assess your patient. So are you gonna be continuing feeding this patient to be like, oh, let me see how fast you're breathing, and continue feeding, or what are you gonna be doing? Call the provider. Okay. Eventually call the provider. What else are we gonna be doing? Stop the feeding, position the patient properly. Definitely. So you want to stop the patient, the feeding, reposition the patient, so that way you reduces the risk for worsening aspiration. All right, you'll also go ahead and try to probably suction this patient, try to get some secretions out, whatever is there. Try to make sure that the oral airway is clear. All right. And you can always go ahead and call over by your x-ray department ahead of time and say, hey, heads up, we have a patient here who's going to need a chest x-ray, things like those, because you're anticipating, that is chest x-ray. So a hospitalized patient receiving enteral feeding develops sudden respiratory distress after a bolus feed. What is immediate nursing action? A, stop feeding and assess for aspiration. Suction and obtain chest x-ray as ordered. B, continue feeding slowly. C, increase feed rate. Or D, administer antacid. So the answer is going to be A. You want to stop the feeding, assess for aspiration. You can suction as needed and make sure that you do your chest x-ray, all right, as order. And that's it. So aspiration risk requires immediate cessation and assessment. Continue feeding slowly. No, the patient is already distressed, so just stop the feed just stop it, because it's just going to be worsening that for the patient. Increase the feed rate. No. All right, so you don't want to go slowly. You don't want to increase the rate. You want to just stop it completely. The patient will survive. You understand? The patient is not going to die from hunger. Administer antacid. That's not really important. All right. Patient not telling you that, they're having any burning or they're having GERD or anything like that. So that's not even important right now. All right. The patient is having respiratory distress. So definitely airway, breathing, circulation. That is priority. Always safety for the patient. All right. So a patient with alcoholic hepatitis shows coagulopathy. Which lab reflects bleeding risk? A, elevated INR and low platelets. B, high albumin only. C, low bilirubin. D, increased hemoglobin. So you have a patient that is alcoholic. They are diagnosed with hepatitis and they're showing coagulopathy. Which lab is reflecting that this patient is at risk for bleeding? A, elevated INR and low platelets. B, high albumin only. C, low bilirubin only. Or D, increased hemoglobin only. So Anne-Marie and Michelle says A. Welcome, Moonbrelly A. Okay, nice. Elevated INR and low platelets. All right. So elevated INR and thrombocytopenia is what you're going to be looking out for. All right. Coagulation factors reduces in liver disease. All right. Because we know that the liver helps with, coagulation itself. All right. So bleeding risk there. So you have an alcoholic patient. Alcoholic hepatitis shows coagulopathy, which lab reflects bleeding risk, elevated INR, and low platelets. All right. A patient with ulcerative colitis on mesalamine reports severe chest pain and shortness of breath. The nurse should A, stop the medication and notify the provider. B, ignore. C, encourage exercise for chest pain. D, give over-the-counter antacid immediately. So you have a patient with ulcerative colitis on mesalamine reporting severe chest pain and shortness of breath. What should the nurse do? All right, so you have a patient that you have with ulcerative colitis and the patient is on this medication. Now the patient is saying, oh nurse, I'm having chest pain, I'm feeling short of breath. What are you going to be doing? Are you going to stop the medication and notify the provider? Are you going to ignore the patient, and saying that, oh, this has nothing to do with the medication you're taking, or B, encourage exercise for chest pain, or D, give over-the-counter antacid immediately. A. All right, definitely stop the medication and notify the provider. All right, so mesalamine, you can have a rare cardiopulmonary reaction because of that medication. So the patient might have the chest pain, they might have the shortness of breath because of mesalamine. So if you know the side effect of mesalamine or the class of drug for mesalamine, then you'll be able to answer this question a little bit better. All right, but if you don't know it, then we always say just go with the one that seems like it's about to hurt the patient. The patient will die from that one. So give over-the-counter antacid immediately. The patient having chest pain and shortness of breath, not gonna really help. So we can put an X beside that one. Encourage exercise for chest pain. Usually if you're having chest pain, we're not gonna tell you to run down there and come back up, so we'll cross that one off as well. You don't want to ignore the patient, concern. So we'll definitely cross that one off. So if you don't know the medication and you don't know the condition, then we're going to leave with stop medication and, notify provider. That's the only option that is there that makes sense. So we'll probably just work with that one. And that would have been the correct one. All right. And then from there. So stop the medication, notify the provider. Rare myocarditis. Pericarditis has been associated with this medication. All right, so that's the answer for that one. A patient with portal hypertension develops hepatic hydrothorax. Which is true? A, fluid. Let's see what. Hold on there. Hepatic. And thank you guys for showing up, for hanging on. All right. Remember to go ahead and top up the live. Oh, let's go up to 20,000 now. Let's go to 20,000. Let's exercise this little finger so we don't have arthritis in there. All right. Let's exercise the little finger here. Hydrothorax. Okay. All right, so a patient with portal hypertension develops hepatic hydrothorax. All right, which is true. So hydrothorax is the accumulation. Okay, so hydrothorax is the accumulation of serous watery fluid in the space between the lungs and the chest wall. It is a condition also known as pleural effusion. It is often caused by heart failure or liver disease with hepatic hydrothorax, fluid related to the liver disease. It's been a common example. All right, so fluid that is associated with liver disease. So you have a patient here with portal hypertension developing hepatic hydrothorax, which is true. A, it is fluid accumulation in the pleural space from portal hypertension. Respiratory compromise is possible. B, it is always indicating pneumonia. C, it requires immediate anticoagulation. Or D, it is not related to a liver disease. All right, so a patient with portal hypertension develops hepatic hydrothorax, which is true. A, fluid accumulation in pleural space from portal hypertension, respiratory compromise is possible. B, it is always indicating pneumonia. C, it requires immediate anticoagulation. Or D, it is not related to liver disease. We have 2 more questions to go, and then that's it. All right, so the answer is gonna be A. It's a fluid accumulation from portal hypertension. Hepatic hydrothorax caused by ascites crossing the diaphragm. All right. Okay. And a patient with acute pancreatitis exhibits bluish flank ecchymosis. What's that called? So what's that called? So you have a patient that has pancreatitis. There is a very special name that we normally call that ecchymosis. What is it? So just like when you have appendicitis that has the McBurney's point, you have acute pancreatitis that has, this bluish discoloration. What is that we're talking about? Colon sign. Grace Turner. Okay, do we have anybody else with another answer? Murphy. It's Grace Turner. All right, it's Grace Turner's. All right, so a patient with acute pancreatitis exhibits bluish flank ecchymosis, which is the Gray Turner sign. This indicates A, retroperitoneal bleeding and severe pancreatitis. B, benign skin rash. C, allergic reaction only, or mild gastritis. So it's actually the retroperitoneal bleeding and severe pancreatitis. All right. And that is usually a poor prognostic sign for this patient. So if you have the patient with acute pancreatitis exhibiting bluish flank ecchymosis, that's the Gray Turner sign. It usually indicates retroperitoneal bleeding and severe pancreatitis. All right. In acute, a patient with massive GI bleed and the BUN rising out of proportion to creatinine. What is this explanation? So you have a patient with massive GI bleed and the BUN rising out of proportion to the creatinine. What is the explanation here? A, increased BUN from digestion or absorption of blood proteins in the GI tract. It's at A, a lab error only, or C, creatinine will always rise faster. D, no significance. So you have a patient with massive GI bleed that has a BUN rising out of proportion to the creatinine. What is the explanation for this one? A, increased BUN from digestion or absorption of blood proteins in the GI tract. B, lab error only. C, creatinine will always rise faster. D, no significance. A, okay, increased BUN and digestion slash absorption of blood proteins in the GI tract. All right, so yes, BUN increased due to me neither, one really. Oh Lord, and got that one correct. All right. Increased BUN from digestion of blood proteins in the GI tract. This one is saying. So an increased BUN from digestion, absorption of blood proteins in the GI tract. So BUN increased due to blood digestion. Upper GI bleeding increases BUN due to protein absorption. We have to read on this one a little bit more. All right, but that was the last question of the night. Seemed to be the one that, I don't really know much about, but yeah. All right, but it was a good live. It was a good live, don't you say? Don't you think so? Oh, we're at 20,000 likes. Nice. It was a good live. We never completed all the questions because we're talking as we go along about different things with the one question, which is nice. But I think we cover a lot. I think we cover a lot for GI night. I think we still have about, but my eyes are tired. I mean, if you go finish my hair I may have patience notes to write. Yeah, don't want Friday to come and have all of those things, you know, to do. So we can do another GI night, you know, with additional questions. It wasn't bad. It wasn't bad. Remember to go ahead and follow me here on TikTok at ThinkNursing and on YouTube at ThinkNursing. Just in case you're missing the live, then definitely you can show up on YouTube and get the full length of the live. All right. So I do stream it on YouTube as well. So go over there and get the full length of the different live streams that I've done so far. Can we get a session for EKGs? Yeah, we can get a session for EKGs, you know. We can get a session for EKGs. All right. We can get a session for EKGs and then from there. All right. We can do some EKG questions, definitely. All right, but it was nice having you guys here. All right. It was nice having you guys here. I see a few persons here joining. Hello, hello, hello. All right, who's that? TS Music and Michelle. Oh, that's Anne. All right, so definitely go ahead and follow my page, and we'll see you in another live. All right, 3:45 here in. Oh my word, I feel like I'm taking you out of your bed at this time of the morning, but then again, you say you don't sleep at night time, so. Hi, TS Music, how are you doing? Vic, welcome, welcome. Yeah, so it wasn't a bad session, but we'll definitely, you know, meet again for more questions and answers on Tuesday and Thursdays, and then from there. Good night, good night. All right, okay, nice, yes. Okay. I am doing good. I'm doing good. Thank you. Thank you for tuning in and asking. But yeah, so we'll definitely be showing up for another live on Tuesday and on Thursdays for NCLEX questions. On Tuesday, it might not be this long because I have work the next day. But on Thursdays, usually it's a little bit longer like this. All right, so we'll try to cover more questions on Thursday. And then from there, good night to you, Woon Braley. Get some sleep now. All right. Thank you for staying up for the entire live. Oh, you're a nurse, Vic? Okay, nice, nice. So we will definitely do that and then from there. All right. But until then, it was nice having you guys. All right. It was nice having you guys. Remember to go ahead and follow and subscribe on my YouTube page. And you can always send me questions. If you have a topic that you want me to discuss or prep, then definitely go ahead and inbox me and I will prep those questions and we come and we sit down and chat about the, you know, the content and then from there. All right, but it was nice having you guys on the live. All right, until then, enjoy your night and I will see you in another live. All right, bye. Let me do this one first.